And those sleep difficulties, more often than not, take the form of insomnia. And so today what I want to do is talk about the gold standard frontline intervention for insomnia, which is cognitive behavioral therapy for insomnia. It's a non-pharmacological approach. And I'm going to go through essentially the theoretical and scientific rationale underlying CBT for insomnia, as well as some of the main components of CBT for insomnia, some of the main treatment strategies within that. And my goal is not to sort of turn you guys into CBT for insomnia clinicians, or have you really even walk away feeling like you can necessarily start to implement this. What I really want to do is increase your appreciation for why this is the gold standard treatment, right? So how it is theoretically informed and how both the theory and the data feed directly into the intervention. And my hope then is that you can start to sort of use that to scaffold the way that you think about insomnia in any population with which you're working, be it a mental health population, a physical health population, healthy controls, whatever it is. Because the beautiful thing is insomnia looks very similar across all of these populations, no matter what the comorbidity is. And the intervention that I'll talk about today works in basically every population in which it's been tested. Almost no matter what the comorbidity is, not almost, truly no matter what the comorbidity is, it works within the population to one extent or another. And so hopefully this can help sort of inform your clinical thinking, inform your research thinking, and just inform sort of the way you approach sleep in your everyday life. So that's sort of on the same page in terms of what I'm talking about when I'm talking about treating insomnia in this kind of context. And I talked a little bit about this Wednesday, but just to remind folks, essentially what I'm talking about here is chronic insomnia, or a diagnosable, clinically relevant insomnia disorder. And this is defined in a relatively straightforward way. So it is, as it says up here, there's sort of three flavors of insomnia, if you will, which is initial insomnia, middle insomnia, late insomnia. That basically means problems falling asleep, problems staying asleep, or problems waking up too early and unable to get back to sleep. And so the question always comes up is, well, how much is too much, right? What is a problem falling asleep? If it takes me 5 minutes to fall asleep, is that too long? Clearly not, right? And so we use the rule of thumb of 30 minutes. If it's more than 30 minutes to fall asleep, if you're awake for more than 30 minutes in the middle of the night, whether that's one long awakening or a whole bunch of short ones, and if you wake up more than 30 minutes earlier than what you would want to, unable to fall back asleep, then that is sort of in the territory of potentially having insomnia. But just having that difficulty falling asleep, staying asleep, waking up too early isn't enough to call it insomnia. In addition to that, you actually have to have daytime consequences for your sleep problems. You actually have to have something that during the day isn't going right, that you ascribe directly back to the fact that you're not sleeping well. Right? And so this is often memory and concentration problems, learning problems. It could just be mood problems, irritability, sleepiness. It can be even something very diffuse, like I just can't quite get my work done when I'm not sleeping well, right? Or something like that. Excuse me, but it has to be some sort of daytime consequence that the individual says, I'm having this problem because I'm not sleeping well. Okay. And then even those two things aren't enough together. You have to then have these problems at least 3 days a week for at least 3 months at a time. And that's chronic insomnia, or what the DSM calls insomnia disorder. And that is the group of individuals then that this intervention was meant to treat and works extremely well with. And part of the problem, I should say, part of the reason that the daytime consequences is such an important part of it is that the problem falling asleep, staying asleep, waking up too early could happen simply because the person is spending too much time in bed. Right? So imagine somebody spends 12 hours in bed. Most adults who are relatively healthy don't need 12 hours of sleep. So if you're spending 12 hours in bed, of course you're either going to have a hard time falling asleep because you're getting in bed at 8 p.m., or you're going to wake up a bunch in the middle of the night because you just don't have enough sleep drive to stay asleep. Right? So that would look like insomnia, but those folks probably wouldn't be complaining of daytime problems. And so then it's not insomnia, it's a different sort of, thank you, a different behavioral intervention, which is they're just spending too much time in bed. Okay, so that's the definition of insomnia. And again, then the other small piece is that if you've got all of these sleep problems and the daytime consequences, but it hasn't been going on for 3 months yet, that's what we call acute insomnia. So that's an acute bout of insomnia. We typically don't see those people in the clinic. Those folks usually aren't distressed enough to come in and try to get treatment. They often don't even go into their primary care doc and ask for medication or anything, just because most people sort of realize, well, sometimes you have a hard time sleeping, it's not a big deal, it'll get better. And then it's not till it builds and builds and builds that it becomes a problem. And in fact, in sleep clinics, we often don't see people until they've had it for a decade. Okay, any questions on the definition? Okay.
What about the sleep inertia? Sleep inertia?
Sleep inertia?
In case of this late insomnia.
So sleep inertia, you definitely can see it in the context of insomnia, like you can in anything. So, essentially sleep inertia will occur, typically it occurs when you first wake up for about a half an hour or so, right? Which is this sort of foggy feeling that you're not quite thinking straight and often feel a little groggy, and many of us reach for caffeine to try to sort of overcome it. It's worse if you wake up out of deep slow wave sleep. And essentially what creates sleep inertia is that metabolically the brain takes longer to wake up than the body. So when you first wake up metabolically, the brain is still at a level that you see during sleep, not at a level you see during wake. And that is sort of leads to this grogginess and fogginess and stuff like that. And it takes a little while for the metabolic level of the brain to get back up to waking levels. So that's sleep inertia. You can see that in insomnia. I don't know that there's any data to suggest it's any worse in insomnia than it is and in some ways it may be less worse because people with insomnia don't get as much slow wave sleep, and so they're not waking up out of slow wave sleep, which is the stage in which is the worst. Okay, so before now I get to cognitive behavioral therapy for insomnia, which is sort of the whole point of my lecture today, I want to just touch on more broadly the evidence-based interventions for insomnia. Yeah. Yep.
His perfect time was 2:10 years ago. He or she is telling that he was sleeping at 11 p.m. and getting out from bed at 7 p.m.
Yep.
Quite good.
Yep.
After he changed his routine, some social commitments, he or she changed his lifestyle and they started sleeping at 2 a.m. and waking up at 9 a.m.
Yep.
Then after that, he or she wants to shift this routine to 11 to 7 again.
Wants to go back. Yep. Yep.
Wants to go back, and trying to go back, but still can't sleep just because of circadian rhythm or circadian food.
Yep.
They have enough sleep drive also. The sleep thermostat is going enough sleep drive. So what kind we can call it insomnia or can't sleep?
Yeah, in that context, did folks sort of hear what Shipra was asking about? Right, so this is someone who slept from 11 to 7 or something like that, and then they shifted really late and went from 2 a.m. to 10 a.m., now wants to shift back and is having a hard time falling asleep. I would, just based on that information, I would be thinking that that's more a circadian disorder than it is an insomnia disorder. And so you would treat it like a circadian rhythm disorder, which Shanta is going to be talking about today? Tomorrow.
Shift work tomorrow, so I'll cover that tomorrow.
Okay. Shanta will talk about that
What's
tomorrow.
the pathophysiology running behind the insomnia? What's the key factors that lead to insomnia?
You're about to find out. So let me just go through and I'll talk about it.
Sure, and I might just also add that it's really common, even though we think of the problem that Shivan was talking about as a shift work problem. It's very common for those people to develop insomnia. And that's complex because what you're about to describe as the CBT for insomnia isn't really appropriate for shift workers because
Yep.
it has, for example, a sleep restriction component. So we don't quite know what to do with that yet.
Yeah. Good point. Okay. So now, I've already, so again, just briefly on the interventions, I've already mentioned that CBT for insomnia is the frontline intervention. Every single peak body, professional body in the world that has put out practice parameters for insomnia has stated that CBT for insomnia is the frontline intervention. That's the first thing people should be getting. And there's very good reasons for that. The problem with that recommendation is there's not enough people out there trained to do CBT for insomnia. And so there's not enough, there's sort of a mismatch between supply and demand for the clinicians. That's led to the development of digital CBT, things like Shut-Eye and Sleepio and sort of online versions of CBTI that they're based on the exact same principles. They do work relatively well. The problem is they're much harder for clients to follow and adhere to, because having the accountability of having to go in every week and see the clinician and talk to them about your sleep and talk to them about whether you've been actually following the recommendations they gave you leads to much better adherence. And so the digital forms, while good, have adherence problems. And they're best delivered kind of in a stepped care model, probably, where you give it to someone, particularly someone who is a relatively clean patient with insomnia. They don't have a lot of comorbidities. They're computer literate and able to sort of follow directions and implement things on their own. And then if they don't respond to that, or they don't adhere to it, then you sort of step them up to inpatient, or not inpatient, in-person care. But, so CBT for insomnia is clearly the gold standard, but most people don't get it because there's not enough practitioners. What do people get? Medications. The problem with medications is that medications, despite what the pharma companies might tell you, they are really best for acute causes of insomnia and very short-term use of insomnia. And there's a ton of meta-analyses out there that look at the medications, that compare medications to CBTI. I'll show you a little bit of data in a second. But this DiCrescenzo study just came out, this meta-analysis and network analysis in the Lancet, which has like several hundred studies, 15,000 plus patients, is a really good overview of the current drugs on the market and both how good they are at treating insomnia and their risk side effect profile. And what they conclude essentially is that S-zobaclone, which is sold in lots of places as Lunesta, I don't know if it's sold as Lunesta here or something else, but S-zobaclone and lemborexant. So S-zobaclone is a benzodiazepine receptor agonist, like zolpidem. Lemborexant is a dual orexin receptor antagonist, or a single, some sort of orexin receptor antagonist. Single?
It's dual.
Dual, yeah. So those two have the best overall balance between efficacy for short-term insomnia and side effects. The benzodiazepines, which are sort of the classic old-school version of hypnotics and are still prescribed far too much in Australia anyway, have the most side effects associated with them. And they are reasonably effective, but they do have a lot of side effects. Melatonin and the related drugs, Romeltian and those sorts of things, do not effectively treat chronic insomnia. They just don't. Now, they're good for shift work disorder. What melatonin does, what have we learned all week? Melatonin drives the circadian system. It shifts your circadian rhythms, right? That's not the problem for the vast majority of people with insomnia. It's not a circadianly driven problem. If there is a circadian component to the insomnia, then these might be helpful. So the case that Shivan was talking about, right? The melatonin drugs could be a short-term Band-Aid for those. What not this meta-analysis, but another one that just came out in Sleep Medicine Reviews, argued that melatonin and its drugs, the related drugs, can be effective for insomnia in adolescents, which makes sense because there's often a circadian component, as we've heard, with adolescents. And there is one meta-analysis that argues melatonin is very good in older adults, say over 65, because of the decreased production of melatonin. But another meta-analysis, the one that just came out in Sleep Medicine Reviews, concluded that it actually doesn't even work in older adults. So clearly melatonin is not the savior that lots of people hoped it would be when it came out and we started applying that. It started being applied to insomnia. So the bottom line really is that none of these medications are particularly good. None of them are particularly good in the long term. So the long-term data for all of these is relatively weak. Some of the Z drugs have a year's worth of data that suggests it works pretty well for a year. But the big problem really is that in the short term, CBT for insomnia and pretty much every drug it's been compared to, and it's been compared to a lot of them, they're equal in the short term. So say over a couple of months worth of treatment. CBT for insomnia is superior to every single one of the drugs in the long term. And the reason is the drug doesn't actually treat the underlying problem that's creating the insomnia. Right? The drug just serves as a Band-Aid and gets the person to sleep tonight. Right? CBT for insomnia actually attacks the problem that created and maintains the insomnia, particularly that maintains the insomnia. And that behavior change is what leads to the long-term benefits. And I'll just show you one data. I've got actually data from lots of different studies, but I'll just show you one. This compared CBT for insomnia to zolpidem, to both. So you have CBT for insomnia, both CBT for insomnia and zolpidem only, placebo. And it was a relatively short treatment session. It was 5 sessions, or the same length, which was 5 weeks. Same length of time with the drug. This is, this first graph is the change in sleep latency. So higher is better because it's more change in sleep latency. The right-hand graph is sleep efficiency. So typically sleep efficiency is one of the main outcomes you look at in CBT for insomnia. But essentially what you can see is that in both cases, CBT for insomnia led to pretty robust changes. Pharmacotherapy led to modest changes over the course of these 5 weeks, but not as big as CBT. And the combination didn't do any better than CBT. So essentially adding the drug didn't really do a whole lot at all. And then placebo obviously didn't see much change. Charles Moore has done a bunch of work comparing CBT for insomnia to pharmacotherapy. And what his data actually seems to argue is that the people who do the best, the people who do the best are either those who only get CBT for insomnia, so no medications at all, or people who get both, like this combination therapy here, but by the time the CBT for insomnia is finished, they've weaned off of the medication. So what he's shown is if you get CBT for insomnia and pharmacotherapy, and then you stay on the pharmacotherapy after the CBT is done, people actually deteriorate. And so you need to pull them off the pharmacotherapy by the time you're done with the behavioral intervention, which is usually around 6 to 8 weeks length of time. So that's, and I think he published that in JAMA as well, or and maybe JAMA Psychiatry, one of those sorts of journals. But so anyway, I don't want to labor too hard on the pharmacotherapy because that's not really what I'm here to talk about. I just want to make the point that there's very good reason that CBTI is the frontline treatment, right? And it's because it just works better in the long term than pharmacotherapy.
Just a quick question. Have people looked at the dual orexin receptor antagonists? The reason why I'm asking you is, if you think of sleep similar to blood pressure or any physical measures, not all drugs work the same way. So have people looked at drugs with different mode of action to see how sleep efficiencies improve? So I'm specifically interested in dual orexin antagonists. Looking very good. What's coming out?
Yeah, they are. And so I don't know of a trial that's compared that head-to-head with CBT yet, because they're still relatively new.
Is it any way to predict, based on what is coming out on its own, improvement in sleep efficiency, insomnia, to how it might be?
I mean, I would predict it still wouldn't work as well in the long run, because a lot of these drugs improve sleep efficiency just fine while you're taking them.
Okay.
But then sort of don't work in the long run.
Over long run.
Over long term. Okay, so let me now jump into really the reason for the lectures this morning, which is what is CBT for insomnia, what's the rationale underlying it. And I always like to start with this quote. So Stephen Wright is an American comedian from like the 80s. And he says, when I woke up this morning, my girlfriend asked me, did you sleep good? I said, no, I made a few mistakes. And the reason I like this so much is it perfectly encapsulates the way we think about, from a theoretical perspective, the development and the maintenance of insomnia. It's all about making behavioral mistakes that then feed into the sleep system and screw it up. And so the treatment is actually about reversing those behavioral mistakes. Teaching people to relearn how and when and where to sleep and overcome the behavioral mistakes that they've made. So let me unpack that a little bit. Okay, so there, you guys might have heard of the 3-factor model or the 3P model. That's a model that Art Spielman developed in the 80s to explain the development and the maintenance of insomnia. Michael Perlis, a number of years ago, added a 4th factor to it, so now it's called the 4-factor model. And this is the theoretical model that is very well supported by data now, that helps us understand how insomnia develops and is maintained. And I want to walk you through it, because if you understand this model, then it's much easier to understand the treatment for insomnia, the CBT for treatment, because CBTI often asks people to make what seem like counterintuitive changes to their behavior. But if you understand the model, then they're not really counterintuitive. So the way this works is, the stages of insomnia are along the x-axis. So pre-morbid just means you're a normal good sleeper, and then acute insomnia, the early phase of insomnia disorder, the longer chronic phase, and then treatment. The size of the bar, essentially you can think of as your loading for insomnia, right? How much loading does the person have? And when that loading level gets above this theoretical threshold, that's when they actually have clinically relevant insomnia. Okay? Now the 4 factors are predisposing, precipitating, perpetuating factors, and conditioned arousal. So everybody starts kind of in a pre-morbid phase. They're relatively good, normal sleepers. And the only risk that people have, the only loading we have for insomnia at this stage are our predisposing factors. Right? So these are risk factors for the development of insomnia. Some of the risk factors are genetic. We know it runs in families. We don't have a good sense of what the genes are at this stage. It's probably polygenic, almost certainly. But there is a genetic component. There's cognitive risk factors, so people who are ruminators, have a hard time turning their brain off, are at greater risk for developing insomnia. There's psychological risk factors. People who have kind of high levels of trait anxiety are more likely to respond to stress with insomnia and develop an insomnia disorder. And there's even social risk factors, right? So we've heard about chronotype. If you are an evening type and you are married to a morning type, and you want to go to bed at the same time as your partner, you're putting yourself at risk for developing insomnia because you're getting into bed when your body's not ready to fall asleep yet. Okay? So there's lots of things that are predisposing factors for the development of insomnia. But just because you have risk factors for the development of insomnia doesn't mean you're going to develop insomnia, right? Everybody in this room has risk factors for cancer. We're not going to all develop cancer. So the question is, who goes on to develop insomnia? Well, now we get into the precipitating events, right? So the precipitating event is the event that kicks off an initial episode of insomnia, right? It precipitates the insomnia. So what are precipitating events? A precipitating event is any event, any stressful life event, where having a few days of sleep difficulties in response to that stress is a totally normal response, right? So you can think of financial stress that makes you stressed out and it's hard to sleep, stress at your job, interpersonal difficulties, you're going through a divorce or difficult relationship problems, stress related to school or taking an exam or having to go to a conference and give your first big talk, right? Any of these things that are stressful events can lead very understandably to a couple of nights of having a hard time falling asleep. And in fact, even good stress can lead to insomnia, right? So planning a wedding is an extraordinarily stressful time in one's life typically, but it's a good stress, but it still can lead to difficulty sleeping. And chronic stress can also lead to it. So you think of sort of long-term systemic racism, for example, right? Can be a chronic stress that builds into somebody developing sleep problems. So any stress in your life that where you basically have an insomnia response as your stress response, can kick off an initial episode of insomnia. Now, most people, when the stress goes away, their sleep goes back to normal, because it's really just the stress that's driving the sleep difficulty, right? But 10 to 15% of the population will go on to develop a chronic insomnia even though the stress has gone away, right? And so we can see here, the stress is down, the precipitating event is down, but the people who go on to continue to have insomnia and develop a chronic insomnia are those who are starting to engage in which are perpetuating factors. These are factors that maintain the insomnia despite the fact that the initial stress is gone. There's 4 types of perpetuating factors. One type of perpetuating factor is things that people start to do when they first develop insomnia, things that they do to try to get more sleep tonight. Right? So if you've developed insomnia, you've had a couple of nights of really bad sleep now, what might you do tonight to try to get a little extra sleep? Go to sleep early, that's one thing you might do.
Wake up late.
Wake up late, that's another thing you might do.
Follow the sleep hygiene.
Napping.
You might try to follow the sleep hygiene, yep.
Napping.
Daytime sleep.
Daytime napping.
Daytime napping, yes, that will fall into the next category I'm talking about, right? So things that you do tonight, napping is really what you would do tomorrow, right? Things that you do tonight would be go to bed early,
Reading.
wake up late, and then one that I talked about last time I gave a lecture, drink alcohol, right? Lots of people, despite my soapbox telling you how awful it is, people will drink alcohol to help themselves sleep, right? So these are things that people will do tonight to try to help themselves get a little bit more sleep. And they might even work, right? If you've been having insomnia, and so you're sort of sleep deprived, you go to bed early tonight, you'll probably fall asleep a little bit early, right? This is why people do it. The second type of perpetuating factors are things that you do during the day to make up for the fact that you had crappy sleep last night, right? And one of the big ones of those is napping. If you didn't get a good night of sleep last night, you might try to take a nap today to make up for it. What's the other major thing that people do during the day when they're sleepy to overcome that? Caffeine intake, exactly, right? Those are the 2 big things. And then there's a third thing. What else might somebody do? They haven't been sleeping well, they're feeling really tired, they don't have a lot of energy. What might they do in that context? What do you do if you don't have a lot of energy? Not a trick question. You reduce activity, right? You don't have any energy. You just sit in the chair and you don't do a whole lot, right? You get sedentary. Right? That's something that people will do in response to insomnia that ironically actually perpetuates the insomnia, and we'll sort of find out why in a bit. So now we've got 2 types of perpetuating factors. Things that you do at night to try to get better sleep tonight, things that you do tomorrow to make up for the fact that you had bad sleep tonight. The third type of perpetuating factor is anything that somebody does in bed other than sleep. So what are the things that people might do in bed other than sleep? Reading.
Chatting.
Listening to music, what were you saying?
Chatting.
Chatting.
Using gadget.
Yep. And chatting's an interesting one, right? Because often, particularly people with young kids, the only time they actually have to talk to each other like adults is when they're sitting in bed before they fall asleep, because the rest of the time they're dealing with their young kids, right? And so we've heard reading, chatting with your partner, which unfortunately sometimes leads to arguing with your partner. I'm sure everyone in here has perfect relationships and nobody argues with their partners. What else do people do in bed?
Watching some videos.
Watching some videos. What do people do everywhere?
Eating.
Exactly. Playing on their phones or their iPads or the whatever, playing on their electronics, right? So, watching TV, reading, talking to their partner, playing on their electronics, eating, right? Lots of things that you can do in bed, Greg.
Sexual behavior.
Sexual behavior would be something that most people will do in bed, and that generally does not involve sleeping. So any of these behaviors, right, you're in bed not sleeping, and these can all be perpetuating factors, which again we'll find out why in just a second. So now we've got 3 types of perpetuating factors. Things you do tonight to get more sleep, things you do tomorrow to make up for bad sleep tonight, anything that you do in bed that isn't sleep. The 4th type of perpetuating factor is any physical or mental health condition that disrupts sleep that is undertreated or untreated completely, right? So we already talked a couple days ago about all the mental health problems that can disrupt sleep. Physical health problems that can disrupt sleep, chronic pain is probably the biggest one. Cancer, diabetes, there's lots of physical health conditions that will disrupt sleep, right? Any of those that are undertreated or untreated can be a perpetuating factor for insomnia, right? So now we've got our 4 perpetuating factors. The question is, why are these things perpetuating factors? Why do these things make sleep worse, right? I mentioned before, if you've had a couple days of poor sleep, now you're sleep deprived, you figure, I'm gonna go to bed early tonight to get a little extra sleep. It'll probably work. You'll probably fall asleep a little bit early, right? Why does it not actually work in the long run, right? If it works tonight, how come it's a perpetuating factor? Well, because you'll probably try to go to bed early again tomorrow night. But you won't be quite sleepy enough to fall asleep right away, so you're gonna lie there awake for a bit, then you'll fall asleep. You think, okay, well, I'll try that again on the 3rd night, and now you're really not sleepy enough to fall asleep, so you're lying around in bed awake a bunch. And that is the key factor here, right? The common denominator of all the perpetuating factors is that people are spending time in bed awake, right? I'm in bed and I'm awake. Think about all the things we just talked about. I'm in bed, I'm reading, that's awake. I'm in bed, I'm chatting with my partner, that's awake. I'm in bed, I'm watching TV, that's awake. Now imagine you've developed some insomnia, you really want to sleep, you're lying there in bed unable to sleep. What's probably going on?
Start headache.
Yep, you can start to have a headache. What else is going on? Anybody ever, their mind wander, they start to think about things?
Or in later stage you lost sleep.
Yeah, right? So you'll start to ruminate, and you'll start to typically ruminate about the things that are stressing you out, so it's not particularly good rumination. That then can lead to negative emotions. Anger, sadness, maybe actually you get frustrated because really all you really want to do is fall asleep. And it's really frustrating that you can't fall asleep, right? So now you're lying in bed awake, but now you're lying in bed and you're ruminating, you can't turn your brain off, you're lying in bed and you're irritated, you're lying in bed frustrated, lying in bed anxious, lying in bed depressed, lying in bed awake, in bed awake, in bed awake, in bed awake. You're constantly pairing these 2 things together. And eventually what happens is the brain figures out the bed isn't a place to be relaxed and go to sleep. The bed is a place to be awake and talk to my partner and read books and ruminate and be frustrated. And so the bed then becomes a stimulus that actually elicits all of these kinds of responses. And we call that the 4th factor, which is conditioned arousal. And the classic conditioned arousal response is that somebody's sitting in the living room, they're watching TV, they're getting really sleepy, their eyes are closing, they think, thank goodness, I'm finally gonna get a good night of sleep tonight. They get up, they go in the bedroom, they lie down in bed, and bam, their eyes pop open, their mind starts to race, they can't turn it off, they can't fall asleep. That's a classic conditioned arousal response because the bed has become a stimulus that elicits the arousal response, the stress response, the rumination response, the frustration response. That now is the solid perpetuating factor of what maintains the insomnia, despite the fact that the initial stress is gone. Right. Does that all make sense? So what we do in CBT for insomnia, the very first thing we try to do is get rid of the perpetuating factors, because these are what's creating the conditioned arousal. And then what we do is we start to chip away at the conditioned arousal. So once the perpetuating factors go down, if you've got a lot of conditioned arousal, you'll still have insomnia, right? You'll still sort of be above this threshold. But then we start to chip away at the conditioned arousal, and now you start to get a good positive treatment response. And the cool thing is, one of the things that makes CBTI better, more efficacious, I should say, in the long run than pharmacotherapy is when you stop taking the drugs, the insomnia often comes back. With CBT, we've changed people's behaviors. We've gotten rid of all these perpetuating factors. We're chipping away at this conditioned arousal. And so if you continue to maintain your new healthy behaviors, you'll continue to chip away at the conditioned arousal. And the long-term follow-up data is actually often better than the immediate post-treatment data. And you rarely see that in any sort of intervention, right? You rarely see that follow-up is better than immediately post-treatment. But you typically see that in insomnia studies because you continue to have this long-term behavior change that continues to chip away at your conditioned arousal and leads you back to sleeping normally. The other beautiful thing about this, for anyone who does interventions, is that CBT for insomnia is typically 6 to 8 weeks. So from a mental health perspective, that's extraordinarily fast to fix somebody's problem. And you truly are fixing the problem when CBTI is successful. Okay, so now that we sort of understand this, we can get into the actual treatment components and how they fit into this model. Before I do that, any questions? Yes?
I think reading the course book or reading literature would make you sleepy rather than aroused. So if you read something else.
It's a very good point. So for some people, reading makes them sleepy. And so it doesn't become, for that person, it does not become a perpetuating factor. You're right. Or if you read the right material, right? If you read something boring, as opposed to something really exciting that you get into, it can make you more sleepy, right? So none of these are absolutes. And what works for one person might actually be a problem for somebody else. That's absolutely true. Yes?
Binge watching.
Binge watching? Yes.
There are a lot of
Yes. And so that, if you're doing that in bed, that's a major perpetuating factor because you're putting together, I'm in bed, I'm awake. And so the brain is learning the bed is a place to binge watch, not a place to go to sleep. Okay, so let's get into CBT for insomnia. So CBT for insomnia isn't one thing. It's a collection of treatment strategies that are put together, right? And so here's the main treatment strategies that appear in almost all versions of CBT for insomnia. Sleep restriction and stimulus control, which I'll spend a lot of time talking about today. These are the ones that carry most of the variance in terms of the efficacy. If you're not doing either sleep restriction or stimulus control, you're not actually giving an evidence-based insomnia intervention. Or at least you're not giving CBT for as an evidence-based intervention. Sleep hygiene is another component. This is the one that almost everybody's heard of. There's been, this week, a couple of people have already talked about sleep hygiene. This is the one that often, if you go to a doctor and you get something other than or in addition to medications, often you'll just get a sleep hygiene handout. They'll say, here, go do this. What we know is that while sleep hygiene helps to set the stage for healthy sleep, sleep hygiene by itself does not treat chronic insomnia. If all you do is sleep hygiene, the person will not get better. Or rather, I should say, will not, they might get better around the margins, but you're not going to fix the CBT for insomnia. Stress reduction and relaxation is often a big component. We sort of already talked about how stress is a major precipitant of insomnia. It can be a perpetuator, so that's there. There is a cognitive component to CBT for insomnia because it stands for cognitive behavioral therapy for insomnia. There's a lot of distorted beliefs about sleep that people develop when they have chronic insomnia that can help perpetuate it. And then, of course, anything in psychotherapy, we do a relapse prevention. So if we help somebody get better, we want to make sure they can stay better and that they actually know what to do should another stress occur down the road so they don't revert back to insomnia. So these are the main components, and depending on how much time we have today, I'm just going to work my way through them. I'm going to spend a lot of time on sleep restriction and stimulus control because, like I said, these are the core components of the intervention, and if you're not doing at least one of these, you're not actually doing the intervention in an evidence-based way. Now, a key feature of CBT for insomnia is you have to know what the person's sleep looks like. You have to know what it looks like at baseline so you know how bad it is, and you have to know what it looks like throughout treatment so you know if it's getting better. The standard way of looking at somebody's sleep is through a sleep diary. And this is one of the sleep diaries that I use. It's kind of the base one that I use. I have an Excel version of this diary that I'm still a little old school still, and so rather than have an app on the phone, I have people use Excel. But the main the main things that you need in a diary, there's something called a consensus sleep diary that the field developed. The main features of that are in this one. So what I do is you fill it out every morning. I should have sent this to you guys and made you fill it out this week, actually. It would have been a good experience. But the main thing you do, you wake up this morning, you fill it out, and you answer these questions. So, how long did you nap yesterday? Sometimes people nap, sometimes they don't. And then here's where you get into the key. What time did you close your eyes with the intention of falling asleep? Right? So that's sort of not when did you get in bed and start watching TV, but when did you actually start to try to fall asleep? How long did it take you to fall asleep? So that's sleep latency, which we've heard about. This would capture sleep onset insomnia. How many times did you wake up in the middle of the night? And of those times, how many total minutes were you awake? So now we're looking at middle insomnia. What time did you wake up this morning for the last time? And then what time did you actually get out of bed? So this helps us see both, basically these two together help us see late insomnia, so it's someone waking up too early in the morning. And then all of these values are used to calculate everything below there, right? So a key one is how long was somebody's sleep opportunity in minutes? You'll also see this called time in bed. So if I get into bed at 10 o'clock and I get out of bed at 6 o'clock, I'm giving myself the opportunity to sleep for 8 hours. That's all sleep opportunity is, right? How much total sleep time did somebody have is of that 8 hours that I was in bed, I have to subtract out how long it took me to fall asleep. I subtract out how many minutes I was awake in the middle of the night. I subtract out how long I was awake in the morning before I got out of bed. Everything else is sleep. So now I have total sleep time. And then finally, sleep efficiency, which is extremely important. I'm sure everybody here knows what this is, right? But sleep efficiency is just total sleep time divided by time in bed. So it's the proportion of time you're trying to sleep that you're actually asleep. In sort of CBTI lingo, we would call it sleepability, which is total sleep time, divided by sleep opportunity, which is time in bed. So we talk with clients, we talk about the opportunity to give yourself to sleep, and then the ability your brain actually has to sleep. And you have to fill this out every week, and there's we have a very formal way of using and evaluating this. I'm not going to get into. What I want to get into now are the specific interventions. Yes, ma'am?
What should be the sleep efficiency? Means, what is the threshold below which is considered as insomnia?
That's a really good question. What threshold of sleep efficiency is considered insomnia? It varies a little bit from person to person when they're doing CBTI. What I use is 85%. If you are 85% or above, I consider that the healthy range. And it'll vary a little bit, right? If you're the population that you're working with, or the person you're working with is an older adult, 70, 75, 80 might be a more reasonable approximation, although we have found very successfully we got people above 85. If you're working with someone in their 20s, you could use 90% as your threshold, because a 25-year-old should be sleeping more than 90% of the time. But as sort of a population level, I'm going to use the same number for everybody. 85% works very well. And clinically, we have found that that's a very good threshold, regardless of the person's age, for determining success in the intervention. But you'll get other people that argue different numbers.
Are they required to be in bed, like we tell them to be in bed for certain hours, like 8 hours or 7 hours, or they you just monitor them, or how does they sleep like?
More of the latter. So we'll answer that question in more detail as I go through these slides. Right. So the question was, how long do you require them to be in bed? And we'll find that out in the next 10 minutes.
So suppose someone is shift worker, so but he's sleeping the same amount as a normal sleeper, so the efficiency will be different.
All bets are off with shift workers, and Shanta's going to talk about them. Shift workers, you can't do this in a straightforward way with shift workers. Okay, so let's talk about sleep restriction, which is one of the two core components of CBT for insomnia. Sleep restriction is also called, at least by me, also called sleep efficiency therapy. And there's two reasons for this. One, it's a more gentle name. When you tell a client, we're going to do sleep restriction, it can sort of freak them out because it sounds like, hey, I came here to get more sleep and you're going to give me less sleep. That's really uncool. So I call it sleep efficiency therapy because the goal is to maximize somebody's sleep efficiency. Right? Okay, so, and I just said, the very first goal of treating insomnia is not to give somebody more sleep, it's to give them more consolidated sleep. You want to get them sleeping in one big chunk before you actually get them sleeping more. And that's what sleep restriction therapy or sleep efficiency therapy is meant to do. And the reason that we want to give people more efficient sleep is that there's pretty good data that shows subjectively, if I get 6 hours of sleep, and it takes me 10 hours to get that 6 hours of sleep, compared to I get 6 hours of sleep, but I do it in a 7-hour window, I'm going to feel much better getting that same 6 hours in a 7-hour window than getting that 6 hours in a 10-hour window. And that sort of intuitively doesn't make a lot of sense. 6 hours is 6 hours, right? But subjectively, people report their sleep was more satisfying, more refreshing, and they feel better during the day if they get that 6 hours in a more efficient way. So that's one of the main reasons that we want to increase sleep efficiency. There's actually also data, I should say, it's not just subjective. There's data that objectively people's cognitive performance is better if they have a higher sleep efficiency, even for the exact same total sleep time. And so it's only after we consolidate sleep and get a high sleep efficiency that we start to grow the amount of sleep that somebody gets. And so insomnia is characterized, as this sort of implies, by a mismatch between sleep opportunity and sleep ability. Right? So most people who have insomnia are spending way longer in bed than they are actually getting sleep. So the typical sleep efficiencies that we see when people come into the clinic can be anywhere from like 40% into the 70%. Right? So people are spending a lot of time in bed and not getting a whole lot of sleep. And this mismatch is one of the major problems, right? Because again, what is the major perpetuating factor? I'm in bed, I'm awake. And if your sleep efficiency is only 50%, 50% of the time, I'm in bed, I'm awake. I'm in bed, I'm awake. That's a lot of the brain learning that the bed is a place to be awake, right? So that's the first thing we have to fix. Now, how do you fix the mismatch between sleep opportunity and sleep ability? So this is just a graph to make it easy to look at. This person spends 9 hours in bed, which is their sleep opportunity. They only get 6 hours of sleep, which is their sleep efficiency. So their sleep ability. So sleep efficiency is 67%. That's pretty bad. We need to get, and you can see there's a big mismatch between sleep opportunity and sleep ability. So in the simplest possible way that you can think about, this is not a trick question in any way, how do you make these two lines get closer to each other? You want sleep opportunity to match sleep ability. How do you get these two lines closer to each other? Less time in bed, or
increase the sleep
or
ability.
increase sleep ability, right? You got to bring these two lines together. If the patient could increase sleep ability on their own, they wouldn't be in your office. If we could increase sleep ability by snapping our fingers, we'd win the Nobel Prize. So this one's out. We can't do this one tonight. What we can do is decrease sleep opportunity and bring it down to match sleep ability. Now, this is the first point in treatment where the client will look at me and say, "You have got to be crazy. I came in here to get more sleep. You're telling me to spend less time in bed. What's going on here?" Right? And so that's why it's extraordinarily important that not only do we understand the rationale, but we explain the rationale of why we're asking someone to do this. Because, as you can see, it's a bit counterintuitive. And if you want people to adhere, they need to know why. So why do we do it? The concept of sleep debt. Right? Shanta did a beautiful job of talking about the two-factor model a couple of days ago. And one of the processes is, two-process model, I should say. One of the processes is process S, the homeostatic process, right? That's basically what sleep debt is built on, right? So Shanta showed this very graph, right, and said, so sleep debt builds up, and the way I explain this to clients is sleep debt is like hunger, right? If we eat something, we're full, we're no longer hungry, our hunger will slowly build and slowly build and slowly build, and eventually we're hungry enough for the next meal. We eat, hunger goes down, the process starts again. That's exactly the way that sleep is regulated, right? Somebody wakes up at 7 o'clock in the morning, They have a sleep pressure, a sleep need, a sleep debt. You can sort of use any of those terms. I tend to use sleep debt. They have a very low sleep debt or sleep pressure. It's not zero, but it's very close to zero. It slowly builds throughout the day, and then eventually, in this example, at 11 o'clock, the person has enough sleep debt that they can fall asleep and stay asleep all night. Right? Sleep debt burns off faster than it builds up, which is why we have roughly 16 hours awake, 8 hours of sleep. And I think Shanta also talked about sleep debt is best indexed by slow wave sleep, which is why there's a fast burn off at the beginning of the night, because you remember we get lots of slow wave sleep at the beginning of the night, and then it slows down at the end of the night when we don't get a lot of slow wave sleep. But that's the normal process. The problem with insomnia, there's multiple problems with this with insomnia, but the main problem is they don't build enough sleep debt to fall asleep and stay asleep all night long because of the behavioral mistakes that they make. Right? So Shanta talked about napping. You take a nap in the middle of the day, your sleep debt goes down. Yes, it starts to build when you wake up, but it's nowhere near where it needs to be at bedtime to fall asleep and stay asleep. Right? What happens, so what did we talk about at the beginning? One of the things people do is they go to bed early when they're having sleep problems, right? What happens if somebody tries to go to bed right here? What's going on with their sleep debt?
More sleep debt.
Right, they need more sleep debt than this to fall asleep. So they go to bed here, they're gonna have a hard time falling asleep. What happens if they sleep in the morning? They sleep until 9 o'clock instead of 7 o'clock. Right, it just not only does sleep debt go down, it starts to build later in the day. So they're starting from low baseline, and then they don't have enough time to build it up to go to sleep. So now they're trying to go to sleep, and their sleep debt's right here. Right? And there's lots of other things that people will do to eat away at their sleep debt. Actually, we talked about staying sedentary during the day. You don't build as much sleep debt during the day when you're sedentary and inactive as you do when you're active. So that's another way that people build sleep debt. And then the other problem is, all other things being equal, the slope of the buildup of sleep debt during the day is more shallow in insomnia than it is in healthy sleepers. So even if they're not taking naps, they're not going to bed early, they're not sleeping in late, this curve is more shallow, so they're still not where they need to be at bedtime. So the fundamental problem is they're not building enough sleep debt. And if the fundamental problem is they're not building enough sleep debt, the solution is to help them build more sleep debt. All that makes sense? How do we help them build sleep debt? We sleep deprive them. So if you continue to stay awake, you'll continue to build sleep debt, build sleep debt, build sleep debt, and eventually sleep debt is so high, it'll overcome your conditioned arousal, it'll overcome the insomnia, the person's gonna fall asleep and stay asleep. Now fortunately, we don't sleep deprive them for 48 hours, which is what I have shown here. They would probably call us crazy for that. But that's the concept. We need to basically create sleep deprivation in a friendly way in order to increase sleep debt and get them sleeping. Okay, so how do we do that? Now we get into what the rules of sleep restriction are and how we build sleep debt. So we know two things. We know we need sleep opportunity to match sleepability, and we know that we need to build sleep debt.
Sorry, just before we move, is this graph valid for both adults and for kids?
Yes, it is valid for both adults and kids. The time scale of the curve is going to be a little bit different in younger kids, but the concept is exactly the same. Okay, so here's the rules of sleep restriction. First, restrict time in bed to the number of hours of sleep. That is, move sleep opportunity down to match sleepability. So in the example I showed you, the person had 6 hours of sleepability, so we make time in bed, or sleep opportunity, 6 hours. Right? The caveat to this is I never go below 5 hours. So some people with insomnia will come in and they'll give you a sleep diary, and you'll see on average they're only reporting 4 hours of sleep a night. Right? But I never restrict somebody's sleep to less than 5 hours. Some people use 5.5. I use 5. And I don't do that for two reasons. One is the less total sleep time somebody reports on a diary on average, the more likely they are to have sleep state misperception, which means objectively they're probably getting a little bit more than the 4 hours of sleep. The other reason is we know from lots of data, restricting somebody to less than 5 hours of sleep a night dramatically increases the risk of accidents the next day. And I don't want to prescribe something that I know is going to increase the risk of accidents. So that's why I use the 5-hour threshold. Now, you have to anchor the sleep schedule to wake time, right? So what we want is the person to be waking up at the same time every day. Why do we want that? Speak up. Yes. Now the murmurs are making more sense. Yes. We essentially want to reset their circadian rhythm every day at the same time. Right? We want them to then be getting light in the morning. We want to take advantage of the circadian system to help us in this process. And the best way to do that is have them wake up at the same time every day. So now, in our example, this person has a 6-hour sleep opportunity. Let's say they want to wake up at 7 a.m. in the morning. That means they have to go to bed at what time?
10?
1 a.m., right? You just do the simple math. They wake up at 7, they get 6 hours of opportunity. That means they have to go to bed at 1 a.m. Now you set that schedule, 1 a.m. to 7 a.m. rigidly. 7 days a week, yes, even on your days off, you have to get up at 6 a.m. or 7 a.m., whatever I just said, 7 a.m., right? So this is another one where they're like, really, Doc, I gotta do this? But you have to set that rigid schedule. You want it the same every day to help reset the rhythms every day and to help build the homeostatic pressure, the sleep drive, the same every single day. So now this person is not allowed to go to bed before 1 a.m. and they can't sleep in later than 7 a.m. That's their new schedule, 7 days a week. Now remember, this person was spending 9 hours in bed. So they used to go to bed at 10 o'clock. And now you're telling them to stay awake until 1 a.m. How the heck are they going to do that? And that's what they're going to be thinking. And it's really important that you help the person think through, how are you going to stay up an extra 3 hours? Or the flip side, maybe they're actually, the way they set their schedule is they're going to wake up much earlier than what they're used to waking up. Same concept. How are you going to actually wake up? How are you going to get yourself out of bed? Right? How are you going to follow these instructions? This is really hard to do, and this is one of the first places people will start to fall down. And you've got a couple different types I've seen a couple different types of clients. One of them are the people who just rigidly do it. You tell them this is what they're supposed to do, they do it, they make it happen one way or another. Great, compliant, adherent individuals. The other set of folks are the ones who struggle. And it makes sense that they would struggle, right? Because they're going to start getting, the whole point of this is to build sleep debt. The whole point of this is to sleep deprive them and make them sleepy. So they do this for 2 or 3 days, they're going to be pretty sleepy. And it's going to be really hard to stay awake until 1 in the morning and get out of bed at 7 a.m. Right? So it's really important that you don't just give them this and send them on their merry way. That you actually take the time to talk about how are you going to actually make this happen. Right? What are you going to actually do to stay awake at night? It's also really important to let them know that sleep will probably get worse before it gets better.
Should we consider their chronotype if we're providing sleep restriction, or suggest them restrict a particular time to go to bed or particular time to go to
Yes, that's a good point. It can be helpful to consider their chronotype, right? Because if they're an evening person, it's going to be easier to stay awake until bedtime, but harder to get up. And if they're a morning person, it's going to be the opposite. So having that information at hand can help both set the window and it can help the problem solve. But what you want to do, it's really important that really what you do is let the client set the window, right? You ask them what time, and typically the way we frame it is, what's the earliest time you have to get up during the week to meet your responsibilities, be that work or school or childcare or whatever it is, right? That's then the time that we have to set as our time to get up. And that doesn't always align with their chronotype, sadly, right? And so that's another thing you do need to think about there. Okay. So now, we have to warn them sleep is going to get worse before it gets better, right? And think about this. So tonight, we're making this person stay awake a lot longer. Does that mean their insomnia is going to magically disappear tonight? No, right? Of course not. So they're still going to have sleep onset problems. They're still going to have middle of the night problems. So they'll still have some insomnia. Their sleep efficiency isn't going to instantly jump to 95% on the first night. Right? So we need to let them know it's probably going to get a little bit worse before it gets better, but that's a good thing. And this is the other time they start to think, how is that a good thing? You're going to make my symptoms worse. It's a good, why? So why is it? Why is it a good thing in the context of sleep restriction therapy that their sleep is going to get a little bit worse before it gets better?
More sleep debt, so they can afford.
That's exactly right? So a couple of you said the same. We're building sleep debt. That's the whole point. We want to sleep deprive them and build sleep debt so that they can fall asleep and stay asleep. Yes, and then I just said the goal is to consolidate their sleep before we grow the amount of sleep they get. And that's exactly what sleep restriction therapy is going to do.
Sean,
Yes?
how much rest, excessive rest during the day will contribute to the insomnia?
How much rest during the day?
During the day, I mean, being lazy during the day.
Yes.
In other words.
So there is some evidence that physical activity during the day helps to build sleep debt faster. So inactivity, sleep debt will build slower, right? And that's becomes difficult for people to make them sleepy. They're not going to want to get out and be doing things active during the day, or many people won't. Right? But you want to continue to encourage them to be active because it'll build that sleep debt faster. Now, what I'm not really going to talk about, right? All of this is really just the very first week. This person isn't going to be on a 1 a.m. to 7 a.m. schedule for the rest of their life, or even for the rest of treatment, right? We're going to move them off of that schedule relatively quickly. Because I'm not really trying to teach you how to do the treatment, I'm not going to talk about that titration process. But maybe at the end in question time, I can talk a little bit more about it if folks are interested. Okay, so why? It all goes back to the 4-factor model, right? Why do we do sleep restriction in the context of the 4-factor model? And I sort of gave a hint with this nice little yellow circle here, right? We're trying to treat the perpetuating factors, particularly the perpetuating factor of the mismatch between sleep opportunity and sleep ability. We're not letting them go to bed early. We're not letting them wake up during the day, not letting them wake up late. We're not letting them nap during the day. We're sort of reducing all of those sorts of behaviors in a very explicit effort to build sleep debt. Okay, so the next thing is conditioned arousal. How am I doing on time? What time is it?
We have still 15 minutes.
15 minutes? Okay. So we'll go through conditioned arousal. Okay, so just like sleep restriction therapy is built upon the base of the concept of sleep debt, stimulus control therapy, which is the other main component of CBTI, is built upon the concept of conditioned arousal, right? And I already talked about the I'm in bed, I'm awake, I'm in bed, I'm awake, I'm in bed, I'm awake, and that leads to the brain thinking the bed is a place to be awake, hence conditioned arousal, right? So, conditioned arousal is a Pavlovian, classically conditioned response. I'm assuming folks know Pavlov and his dogs and the conditioned response and all that stuff, yeah? So this is a classically conditioned response. And again, thinking about working with clients, I explain to them what classical conditioning is. If they don't happen to know Pavlov's dogs and haven't sort of heard about that, I tell them a little story and essentially get them to kind of understand what does it mean when I say I'm in bed, I'm awake, I'm in bed, I'm awake, and that conditions the brain to say that the bed is a stimulus to elicit wakefulness, right? So you sort of make sure that they kind of understand that. And then I talk a little bit about, there's examples of classical conditioning every day in our life. So a common one is if you're walking down the hallway and someone sees you and says, hey, Sean, how you doing today? Right? Most of us have sort of an automatic response that we give. It doesn't matter how we're doing. We're like, fine, how are you? Right? We don't tell them we're having a really crappy day. That's a conditioned response. Essentially, someone says, hi, how you doing? Something spews out of your mouth whether you mean it or not. Right? Other conditioned responses are often around food. So often we can be totally satiated, just ate a beautiful meal, walk in the room, and we see our favorite food or smell our favorite food, and we either salivate like Pavlov's dogs, or we get hungry, or we start to remember some event that is related to why this is our favorite food, you know, whatever it is, that's, again, a triggered automatic classical conditioning response. Right? So these things happen everywhere in our life every day. So it's not surprising then that it's going to happen as it's related to sleep, which is a third of our life. So it's completely understandable. And the reason I sort of go through this in this sort of way is I want to take away any guilt that the person has, right? Because go through the 4-factor model with a client, essentially what you're saying is all these behaviors that you're doing, you screwed your sleep up. You know, they can hear it as, oh my gosh, it's my fault I have insomnia because I did all of these things, I have all these perpetuating factors, I created all this conditioned arousal, this is all my fault, right? And essentially this is an effort to reduce that guilt and the anxiety associated with that. This just happens naturally. Okay, and again, when you're thinking about what's creating conditioned arousal, you want to think about what is the person doing in bed, reading, talking to their spouse, watching TV, whatever it is. What thoughts are going through their brain, right? Are they ruminating about stress? Are they might even be ruminating about good things, right? They just can't turn their brain off, what's going on. And what are the emotions, right? Is there frustration that they can't fall asleep? Are they pissed off because they had an argument with their spouse? What are the emotions that are going on? All of those things combine to create the conditioned arousal response. Okay, so stimulus control. With sleep restriction, there are a whole bunch of rules, and I only kind of gave you the main rules of sleep restriction. Stimulus control, there's one rule. Very easy to remember. Do nothing in bed but sleep, and sleep nowhere but the bed. Maybe that's technically 2 rules, I don't know, but I think of it as one rule. Do nothing in bed but sleep, and sleep nowhere but the bed. Right? So the idea is I'm in bed, I'm awake, I'm in bed, I'm awake. You want to break those two things apart and put together, I'm in bed, I'm asleep. So that the brain relearns that the bed is a stimulus to elicit relaxation and sleep. Right? So in contrast to do nothing in bed but sleep and sleep nowhere but the bed, you can have stimulus discontrol. So this is my cat Cinda sitting on her bed. We're not allowed to use this bed. This is Cinda's bed, but she's wide awake. So she's violating stimulus control by doing something in bed other than sleeping. This is me at age probably 8 or 9, clearly wide awake in bed, wearing clothes. I have no intention of going to sleep. I have no idea if my parents wanted me to go to sleep, but clearly I have no intention of going to sleep. Again, poor stimulus control. Sleep nowhere but the bed. Cinda, being a cat, can sleep anywhere. And so this was a common lockdown scene with Cinda sleeping in the desk drawer, making it very hard for me to work on my laptop. Terribly cute, but it makes working very hard. And then me, at age 3, again, fast asleep somewhere other than the bed. And you can tell I was an audiophile. I got the old school headphones on. No idea what I was listening to. Anyway, just a little random silliness to break up the day. Okay, so what really are the rules of stimulus control? Right? And again, really, if you remember, do nothing in bed but sleep and sleep nowhere but the bed, you can figure out what the rest of the rules are. But here are the rules. Only go to bed when you're sleeping. Right? So our person's bedtime is 1 o'clock in the morning. If they're not actually sleepy yet at 1 o'clock in the morning, we don't want them getting into bed. And why is that? Exactly. They'll be conditioning themselves to be in bed awake, right? And this is really frustrating for people who are undergoing treatment. Sometimes they're not sleepy at bedtime. Like, oh my God, I waited till 1 in the morning and now I still can't get into bed. Don't use the bed or bedroom for anything other than sleep. Again, we don't want I'm in bed, I'm awake, I'm in bed, I'm awake. There is an explicit carve out for sex. So really the rule is don't use the bed for anything other than sleep and sex. If you're unable to fall asleep, and this is the part that makes it really hard. If you're unable to fall asleep in 15 or 20 minutes, you need to get out of bed and go somewhere else. And why is that?
Conditions.
Yes. The combination of all of those answers, right? If you're in bed for 15 or 20 minutes awake, I'm in bed, I'm awake. Right? You're getting conditioned arousal. That's not what you want to do. You need to get out of bed, go somewhere else until number 1 happens. You're sleepy enough to go get back in bed and hopefully then fall asleep. Now, the thing that, again, makes this difficult is we don't want somebody watching the clock. Because if they watch the clock, if they think, all right, I have 15 minutes to fall asleep, or Sean said I have to get out of bed, they're going to lie there and they're like, I have 12 more minutes, I better fall asleep, I better fall asleep. Oh, I only got 10 more minutes, I better fall asleep. You're going to actually make the problem worse, right? So they have to hide the clock, and then they're like, how am I supposed to know if it's been 15 or 20 minutes? You just told me to hide the clock. Okay, so what we do is we say, what if you find yourself engaging in your perpetuating factors, if you find yourself ruminating about all of those things, if you find yourself frustrated that you can't fall asleep, that's probably the time you need to get out of bed because you're starting to create conditioned arousal. Right? If, on the other hand, you're lying there, totally peaceful, you're not at all stressed, you're not at all worried, maybe it's been a half an hour, you don't really know because you don't know how long it is, but you're not creating the conditioned arousal because you're relaxed, you're calm, you're not ruminating, you don't have negative emotions. So there's nothing super magic about the 15 to 20 minutes. It's more about, is the person creating conditioned arousal or are they not? So that's why the clock isn't so important. But you get out of bed, you go in the other room. There's a couple of instructions what to do in the other room. What I say is you go into the room, a dimly lit room, so you're not flooding yourself with light, because we've heard all week how bad light is in the middle of the night for the circadian system, right? And you do something relaxing, calming, that gives yourself the opportunity to become sleepy. And what that thing is that somebody does can vary from person to person. Right? What I find calming and relaxing may not be what you find calming and relaxing. And so some people might read a book, some people might do crossword puzzles or some sewing. I typically discourage people from getting on their electronics because then you sort of get the blue light. I discourage people from doing something that's going to absorb all of their time and attention, and so they'll lose track of time. Right? So when I was, many years ago, when I was reading the Lord of the Rings books, I would read and read and read, and like next thing I knew it was the middle of the night because I was just completely absorbed in the book. Right? That's not something that I would necessarily want the person to do. I want to be able to them to do something, whatever it is for them, that is calming, relaxing, gives themselves the opportunity to fall asleep. That's my position. There's another equally valid position that says, I don't really care what you do in the middle of the night when you get out of bed. In fact, fine, read that book that's going to absorb you and you're going to spend 3 hours reading before you know it. Because what's the worst thing that's going to happen if the person ends up staying awake for a long time in the middle of the night?
You sleep debt.
Exactly. You're just going to build sleep debt, and building sleep debt is a good thing. Right? So, again, there's a very strong school of thought that sort of takes that approach. I don't do that simply because I don't really want the person only getting 1 or 2 hours of sleep in the night, even though that is a good thing. You're going to fall asleep quickly tomorrow if they do that. Leads probably to more problems during the day if they're that sleep deprived, right? So you find some sort of happy medium. And then this one overlaps with sleep restriction. Wake up at the same time every day, regardless of how much or how little sleep you've got. This is to help reset your circadian rhythms, and it's to help build sleep debt. And then finally, avoid taking naps. So this is another one that overlaps with sleep restriction. And the reason that there's some overlap is that there's very good data to show if you only do stimulus control and you don't do sleep restriction at all, the treatment will still work. It works slower, but it will still work. And if you only do sleep restriction and you don't do stimulus control, the treatment will still work. So that's why we put that's why the creators of this put some overlap in. Okay, so why do we do stimulus control? The main reason we do stimulus control is conditioned arousal. You're trying to break apart, I'm in bed, I'm awake, I'm in bed, I'm awake. The other reason we do stimulus control is that we're going after a perpetuating factor, and the perpetuating factor is poor stimulus control. Well, that's sort of a trick question. We do stimulus control in order to treat bad stimulus control. What does that actually mean? So that means this. On the left-hand side is somebody with good stimulus control. At bedtime and in the bedroom, there's only 2 things the brain can think to do: sleep or have sex. Pretty good odds of going to sleep. On the right-hand side is poor stimulus control. In this case, when the person goes into the bedroom and gets into bed, there's lots of things that the brain can think to do. Eat, read, watch TV, work in bed, worry in bed, argue with their spouse. Lots of things here, right? So there's only a 1 out of 8 chance that the person's going to that the brain's going to choose sleep. So the whole point of stimulus control is to get rid of all of those sleep incompatible behaviors, get rid of all those things driving conditioned arousal, and move the person from the right-hand side to the left-hand side of the graph. Okay, so I'm going to stop there. Happy to answer questions on anything I've talked about so far. We can take our tea break, come back. I'll sort of finish up.
Still have time for questions.
Questions if folks, yes?
Does it help for the people who wake up often in the middle of the night also? Like they have a routine of waking
Does
up?
this help? Yes, absolutely. Because what happens is you're building enough sleep debt through these strategies that the person will fall asleep and stay asleep. So there's enough sleep debt to push them through the entire night.
Then like they are breaking the sleep cycle, or they are waking in the middle of the night again. They have to fall asleep, follow the same routine again.
So yes, so if somebody wakes up in the middle of the night, they do have to do stimulus control. So if they're awake and they lie there awake for a half an hour, they should be getting out of bed, doing the stimulus control, and then getting back into
They
bed.
will be taking longer time.
Yes, they will be taking a longer time, right? Which means they'll get a little bit less sleep tonight, which means what good thing is going to happen?
Less sleep debt and they have to build that sleep debt.
Exactly, they're going to build more sleep debt the next night. And so bad sleep tonight predicts an easier time sleeping tomorrow. Okay? And that's one of the things we constantly sort of remind people. It may not go well tonight or on any given night, but that's okay, because the worse it is tonight, the easier it's going to be tomorrow night, because you're just building more sleep debt.
Treatment will take longer.
It wouldn't necessarily take longer. I mean, almost nobody, there are a few cases, almost nobody the very first night of sleep restriction starts sleeping perfectly and then they're just done, they're fixed, right? What we found, we actually are getting ready to publish some data. What we found is if you look at how long somebody has to do sleep restriction before, so what I didn't say is when we're going through sleep restriction, the person's still filling out the diary. When they come back and they have a week where they average 85% or more sleep efficiency, so we've gotten them up to that magic threshold, then we increase the amount of time they have in bed. So we increase sleep opportunity by 15 minutes at that point. So in our theoretical example, the person comes back, they've got an 87% sleep efficiency. Now, for the coming week, they get to go to bed 15 minutes early. So now they can go to bed at 12:45 and wake up at 7. And we sort of slowly increase sleep opportunity that way. Right? There was a reason I was telling you that. What was I? Wow, that was just completely gone.
Sleep, right.
What was I? Totally. What was I talking about? Dun, dun, dun. Oh, right. I know what I'm saying. Right. So we have data where we looked at how long is somebody doing sleep restriction before that first time that they have an 85% sleep efficiency and they get time back. What we found is 43% of our cases got time back after the first week. So it only took 1 week worth of sleep restriction before we got their sleep efficiency up to 85% and they started getting time back. Another 25% did it in 2 weeks. And another, let's see, what's 43 and 25 is 68. So another 11 or 12% did it in 3 weeks. Right? So we had something around 80% of our clients had 3 weeks or less of sleep restriction before they started seeing clinically valuable improvements and they started getting time back. But the big thing is 43% did it within a single week. So this is a very fast-acting intervention for most people. And even 3 weeks is super fast from a psychological intervention perspective. Right? So it works very, very well. Now, obviously, just because they start getting time back doesn't mean that their sleep is exactly where they want it to be, because our poor hypothetical person, they're still only in bed for 6 hours and 15 minutes, and then 6 hours and 30 minutes, 6 hours and 45 minutes. So it takes a while to build it up to a more satisfactory amount, which is why the treatment usually lasts 6 to 8 weeks. Okay, any other questions before we break? Yes?
Have you ever thought about the interval between the last meal and the time going into the bed? has happened that many people do start working in between the time which is available to them, which can be 4 hours, 5 hours. Because of the electricity, we have no control.
That's right.
So they have, whether they have meals 7 o'clock or 9 o'clock, doesn't matter regardless. But then they start working. So during course of, and to personally this, I think this because your activated brain,
Yeah, totally.
physically sitting activated brain compromises the sleep constantly.
Yes.
So this is always good for those people, in my opinion, if you do a test that last meal and the time to get. It should be approximately 3 hours or 2.5 hours. But during that time, they only just relax. If they watch TV, the relaxing one. And if they do any activity which is a relaxing one, you mentioned one, but there are others.
Yep.
And not reading the book, relaxing one.
Yeah, so
And
I
these
agree with
people have
yeah.
stopped doing that.
Yeah, I agree with a lot of that. In fact, I'll be talking more about those issues when we come back from break. So let me pick that up when we come back.
Sir, like
Yes.
if one person is following a continuous good sleep routines, but still like the position also matter. Like if some person is sleeping in other bedroom that is not getting sleep or going in some other place. So what is that?
Surrounding. So changing the place.
Where they're sleeping?
Yeah, I mean that might affect the sleep
Yeah.
first day. Several of us encounter this.
Yeah. So the
Not in your own bedroom.
Yep, yep. So from an insomnia perspective, right, conditioned arousal, I'm in bed, I'm awake, is often conditioned to the specific bed and bedroom. So what you find, often people with chronic insomnia, if they go to a hotel, they sleep much better because that's not where the conditioned arousal is, right? They still have the problem of not building enough sleep debt, so it doesn't necessarily solve the problem. But for people with a very strong conditioned arousal, changing the environment can actually lead to an acute sleeping better. It won't last long, but they can break that conditioned arousal to their specific bed. So then it helps them, but it's not a long-term fix. It's a very short-term thing.
There's some kind of light helps, like red light.
No.
So there's no light that promotes sleep, right? There's just light that destroys sleep. Yeah.
So, Sam, do you think that mental stress during the daytime could influence the sleep at night?
Do I think that what during the daytime?
So, a lot of brain uses during the daytime
Mental
versus the
stress.
free
Yeah, it's a
during
good
the
question.
daytime.
So there isn't good data that being mentally active during the day makes you sleep better at night. The data is more around physical activity during the day. And interestingly there, what the data shows very clearly is that somebody who is chronically physically active, they're in very good shape, particularly cardiovascular conditioning, sleeps better during the night. The data on if I work physically really hard today and wear myself out, am I going to sleep better tonight, which is what most of us think, that data is really equivocal. There's some studies that show, yes, if you physically tire yourself out, you'll sleep better. There's other studies, probably an equal number of studies, that say no, that actually doesn't influence sleep quality at night. So it's a little bit unclear whether acute exercise during the day makes you sleep better tonight. But what is abundantly clear is that being a chronic exerciser makes you sleep better overall.
Yeah.
But I haven't seen any data with mental activity, which is really what you're asking me, right? I haven't seen any data that vigorous mental activity during the day influences one way or the other sleep.
Not mental exercise, mental stress. So, you know, if you are stressed for some reason.
Oh, mental stress.
Yeah.
Oh, I'm sorry. That would have a very negative impact on sleep, actually. Yes.
The problem is on that if you do an exercise during the day with the view that it is going to promote the sleep, itself is a kind of stress you are creating yourself.
Yeah.
Because
sure.
you have goal oriented.
Yeah.
And that is why it's a physical activity, not running around all the time, because it doesn't help. It may not help, but
Yeah.
physically, so there are several people who just don't do it. I mean, always sitting on the computer and doing something. which is no good. Many professors I
Yes.
see just
It is
enter
no
into
good.
the room, never get out. I never sit more than 30 minutes. I get done more than them during the day.
Yep. Yep.
So it's being physically active, it means, and you try out this, I'm pretty sure having not, having good meal, relaxing, but too much oil and indecisive, and having a 2 or 3 hour interval before
Yes.
it helps.
It totally helps, and I'll talk about that exact concept when
Yeah.
we're done. So why don't we take the break now?
Yes.
Get some tea. I usually frame it more around, so talk about what are the daytime problems that the insomnia is creating, and then why do you want to change that now, right? What are you helping to improve? And most people who want to treat their insomnia or really any kind of mental health disorder have motivations. It's not just I want to reduce my symptoms. It's they want their life to get better in some other way, right? And so you help to sort of talk with them about what are those other ways. So maybe I want to be less irritable with my kids, or I feel like if I'm sleeping better, I can actually be even more productive at work, or whatever it is. It's going to be a little bit different for every person. And then you help them to see, well, in order to accomplish that goal, you've got to change some behaviors and start sleeping a little bit better. And so you have to help them build that intrinsic motivation. Because as you've seen already, there's a lot of behavior change that's involved with the behavioral intervention of insomnia. And somebody has to be motivated to make those behavior changes. They're not easy. And so motivational interviewing techniques are one way to help the person build that internal motivation to do it. Interestingly, the other thing I've seen though is in very perfectionist type A people, they want to do this right. You give them the instructions, they're like, that's what I'm doing. Those are the instructions, I'm going to do that 100% correctly. So you actually, in essence, are taking advantage, the same personality that creates the problem, you're taking advantage of helping them to take advantage of in order to treat the problem. Because now they're going to be perfectionist around following the rules. And you tell me to stay awake till 1 o'clock, I'm going to stay awake until 1 o'clock. You tell me to get out of bed at 7, I'm getting out of bed at 7. And so that actually ends up becoming an advantage, and they're able to better adhere to the intervention. And then once the biology kicks in, once the sleep debt starts to build, once the conditioned arousal starts to go down, it becomes very self-reinforcing, because now they see, oh, I've done this for a little while and I'm actually sleeping much better. I feel much better during the day. And they start to live all the things that you're talking to them about. And then that, getting a little bit of gain becomes reinforcing. And now they want more gain and more gain and more gain. And then that's what keeps them going throughout. And so there's sort of the two different, and I typically try to do a little bit of both. You do a little bit of motivational interviewing, and then you do a little bit of sort of jujitsu, perfectionist anxiety that created the sleep problem in the first place. Rather than becoming an advantage, can actually become a disadvantage, because now they feel like if they aren't doing it completely perfectly, then they're messing it all up. And they have like a performance anxiety about doing it right. And that anxiety then makes things worse, right? And so it's a little bit different with every patient. And you have to take a little bit of time to get to know the person and figure out sort of where is the strength and weakness that you can work with that person. Which is why this is, it's in Australia and the US anyway, this is hard for physicians to do from a time management perspective, right? When I do this, I see somebody once a week for an hour for 6 to 8 weeks. That's impossible for most physicians to do, right? You don't have it in your schedules to see somebody for an hour a week. And so it makes it challenging, but that's what's required for these kinds of behavioral interventions to really be successful. That might have been a little bit more of an answer than what you were talking about.
I was wondering if there's any data on the ambient temperature of the room also. Like, I heard that a lot of people like a room colder, but you like or something like that.
Yeah, so there are some data on that, and it's a pretty wide dynamic range in terms of what the optimal temperature is, and it's going to be a little bit different for every person. The sort of stereotype is that if the room's a little bit colder, but you can use blankets. But the reality is too cold, it's hard to sleep, too hot, it's hard to sleep, and everybody needs that sort of Goldilocks middle ground. But that's going to be a little bit different for every person. And that then can lead to obviously some tensions in relationships. If I like it cold, but my partner likes it hot, then you have to sort of figure out some way to find a middle ground. Or you have 2 blankets, or sometimes people just end up sleeping in different rooms. But yes, there is a dynamic range of that temperature, but it's going to be a little bit different from person to person.
In terms of degrees?
In terms of degrees, the numbers that I see thrown around the most are like 16 to 20 Celsius, somewhere in that range.
It's cold for us. It's 23, 24.
Yes. Well, like if it's 16, I'm dying. I'm like putting my puffy jacket on, and I don't do well in cold. Like the temperatures here have been killing me this week. But that's because I'm from Southern California originally, where it's beautiful and warm all the time. Although not as warm as here.
But also, it is more about the temperature at your extremities which matters. So lower extremities.
Yes, it actually, the hands, the feet, and the forehead.
Yeah.
Right, that's where we lose most of our heat. That's where you need, you're absolutely right, that's where you need the temperature regulation. And I think actually I'm going to talk about that a little bit from a sleep hygiene perspective. Any sleep position that is best. So whichever one you're comfortable in. That's right, there is no perfect position, no ideal position. In terms of its effects on sleep, right? Obviously there's some positions that are harder on your lower back and hips, right? So if you're lying completely prone, that's much harder on your hips and your lower back. But that's more sort of a structural issue, not a sleep per se issue. But it's whatever, it's the same thing with surface. Like a lot of people ask, what's the ideal mattress? And of course, all the mattress manufacturers are going to convince you that their mattress is the perfect one to give you the best night's sleep you've ever had. It's all nonsense. The best mattress is the one you're comfortable sleeping. Some people like it firm, some people like it soft. If you like sleeping on bricks, sleep on bricks. Nails, great. Sleep whatever you're comfortable, right? And if you like a feather down little pillow that you sink into, perfect. Sleep on that, I don't care. Whatever you're comfortable with, that's the best one.
When I went for the first time to England, and I was invited in Cambridge or Oxford, so in a hotel room I never used to sleep on the bed, it was too soft for me. So I would pull over the bed sleep.
Put them on the floor.
On the floor I will sleep with a pillow.
Yeah. It really is. It's whatever you're most comfortable with.
Are there any sound frequencies that help you to sleep?
That's a really good question. Are there any sound frequencies that help you to sleep? And so I'm not sure about the exact frequency, but what has been shown is that white noise can actually help somebody sleep because it blocks out all that stuff we're hearing from outside. If you're in a really quiet room, the white noise doesn't give you added benefit, right? So the white noise works because it blocks other things out. But again, to some extent, it's personal comfort, right? So I've talked to people who grew up in New York City, which is a very loud, noisy, right? It's like all the honking and stuff we're hearing out here. They have a hard time sleeping when it's too quiet, because this is what they're used to. Personally, I need it much more quiet when I sleep, and so if I was having this sort of noise out my window, I would be turning the fan on or putting some sort of white noise to help myself sleep. Something that isn't helpful from a noise perspective, so the key to noise helping somebody sleep is when it's constant, like white noise. Or some people now are all hot and heavy over pink noise, and they think that that's way much better. I haven't seen any data on that. But what isn't helpful is ballistic noise. So some people swear they like to fall asleep listening to a podcast or with the TV on or something like that. That sort of ballistic noise that's constantly changing frequency and volume is actually very bad for our sleep objectively, even if subjectively the person swears it's good for them. Same is true being on a train line or in the flight path of an airport. People will tell you, oh, I don't even hear the trains anymore, I don't even hear the planes anymore. But when you study their sleep objectively, they do arouse when the noise comes by. So you get this kind of subjective habituation that doesn't translate into objective habituation. Now, somebody can be in the flight path and the plane's going to be disrupting their sleep all night. If it doesn't bother them and they don't have consequences during the day, they don't have insomnia, right? So it truly isn't a problem in that context. But for somebody who has insomnia, it can be one of those contributors that the person isn't aware is contributing. And so it's always worth kind of investigating what the sleep environment is like in that context.
So what I understand is that want to sleep soundly.
Yep.
You don't recommend listening to a podcast and sleeping.
That is correct. So I would recommend the podcast get turned off before you fall asleep. Right? So some people will listen to a podcast and it helps them relax before bed. That's totally fine. It's once you're asleep, you don't want the podcast on anymore. And so sometimes, like some phones, you can have a timer that it'll shut off after an hour or whatever, right? And so if you do that, fine. But in terms of noise all night long, the white noise is far better than something like a podcast or the TV or the radio or something like that.
And what you were saying, Jill, that about the room temperature, do you think that core temperature, bringing down the core temperature of the body while sleeping?
Bringing down the core temperature.
You have certain, mattresses now which really lower the temperature.
Yeah. No, that's a good point. So you do want the core body temperature low when you're trying to fall asleep. And there's a couple of tricks. In fact, I'll talk about it in just a second. There's a couple of ways you can help bring that core body temperature down. But yes, you do need the core body temperature low. Because remember the other day when I was talking about the effects of alcohol, one of the reasons that alcohol disrupts your sleep is it drives your body temperature up, and that's bad for sleep. So I'll talk a little bit more detail about that in just one second.
Sure.
Anything else on what I talked about?
Quick question, so are these conditions, what you say, different between a person who's a healthy sleeper and an insomniac, as in like don't listen to music? The reason is because there's always been a culture of singing lullabies to babies to put them to sleep. And I think even from personal observation, it always helps that putting some soft, not thumping music, rock music. Maybe it's just a few, but for most, gentle music puts people to sleep. And also, is the data to show whether music is good for sleep initiation versus sleep maintenance? Maybe it's good for sleep initiation, but not maintenance.
Yeah, it's a good point, Sri. And I think, so yes, the rules are different for healthy sleepers versus someone with insomnia.
Okay, great.
So in a healthy sleeper, they can often get away with breaking some of the rules and still sleep fine.
Yeah.
Right, so I think of sleep hygiene. In fact, I think this is my next slide. Yeah, I think sleep hygiene obviously is a set of rules that are behaviors that help maintain healthy sleep-wake cycles and help set the environment for healthy sleep and set the environment for healthy wake. I think of sleep hygiene like oral hygiene. If you have very good oral hygiene, you brush every day, you floss every day, you go to the dentist on a regular basis, you can afford to break a couple of rules. You can skip brushing your teeth or flossing for a couple of days and you're not going to get a cavity. Your teeth aren't going to fall out. You can eat some extra sugary stuff and your teeth will still be plenty of healthy because the rest of your sleep hygiene or oral hygiene is good. But if you have really bad oral hygiene and not flossing and not brushing and that sort of stuff, then your teeth are at much greater risk of eating some extra sugar is going to give you a cavity. Right? Same thing with sleep hygiene. If you're a really good sleeper, you can break some of these rules. I don't adhere to 100% of the sleep hygiene rules. Pretty close, but not 100%. And you can get away with it because you're a good sleeper. But as soon as you develop insomnia, one of the things I talk to people about doing is clamping down 100% on all of these rules. And then once we finally get your sleep back to normal, then you can start trying, if I cheat on this rule, does it hurt my sleep or not? If I break this rule, does it hurt my sleep or not? So yes, it's definitely a matter of, I should say the rules are the same for healthy versus people with insomnia, but healthy sleepers can get away breaking some of the rules.
I would just like to add that lullaby is usually associated with rocking, isn't it? So it is not a controlled condition that you're just singing a lullaby and...
Rocking is much more of a phenomenon in some culture than not in all. So that's variable. In fact, for the rocking, there have been a series of paper on vestibular control. I was speaking to one of the students here on the vestibular state system directly contributing. There was a current biology paper where they rocked mice to sleep. the time to fall asleep significantly decreased in mice and across species. Just the idea of rocking at 1.5. So
Shipra did this study in Russia.
yeah.
Published in PNS.
Yeah.
And there's actually at least in the US and Australia, I don't know if you can get it here, there's a product called the SNOO, SNOO, and it basically is a product that, it's sort of a crib, and it swaddles the baby, and then if the baby starts to make a certain amount of noise, indicating that it's awake, it starts to rock automatically. And it also makes this whooshing sound that the inventor claims is the same sound that babies hear in the womb. And there's actually some decent data to suggest this device helps babies sleep better.
Yeah,
And then it helps the mother sleep better because the baby's sleeping better.
do they have one for adults as well?
I don't know if there's an adult size.
They have the vestibular stimulation devices,
Yeah.
right, to simulate the same rocking sensations. So Philips had one, a vestibular stimulation thing that basically something that just went into your ear that pulses.
That's a good thing.
I didn't realize they have it. Thanks.
Yeah. Okay, so sleep hygiene. Good sleepers can break some rules. Bad sleepers cannot break rules. There's three. I think of sleep hygiene you can break down in a lot of different ways. I try to keep it simple and sort of break it into three categories, right? Things to avoid, and there's the most number of things on that one. Things that promote sleep at night, and then things that help you stay awake during the day. So what I want to do, because we got lots of time, and I don't have that many more slides, I'm going to go through these and spend some time talking about them. So before I start talking about these, just look through these ones that are things to avoid. And tell me if there's any of them on here that seem surprising to you, didn't expect, or that you want to hear more about kind of the rationale and the science behind why these are sleep hygiene rules.
So regarding polyphases, like taking multiple naps, it's not possible for us to sleep in 1 to 5 to 6 hours. Is it possible to maintain sleep hygiene by taking polyphasic?
So is it possible to maintain good sleep hygiene taking multiple naps? So clearly you're a physician. Yes. So I think that when you get into polyphasic sleep, there's lots of sort of issues, right? One is the argument about historically were humans actually polyphasic sleepers or not. There's obviously some anthropological data that suggests that at least some cultures were typical polyphasic sleepers, usually 2 bouts, not a whole bunch of them. But is that the way we evolved or didn't evolve? And that sort of doesn't, clinically, that doesn't even matter to me, right? The question is, practically speaking, if you can't get 8 hours of sleep overnight, is it better to do polyphasic sleeping? And this also will get in, I'm sure, a little bit what Shanta's talking about in terms of treating shift work sleep problems. But the reality is, if it is literally impossible to give yourself enough sleep opportunity overnight to get sufficient sleep, then yes, napping is a way to, or breaking your sleep up into polyphasic sleep is a way to get that 24-hour sleep need met. And the question is, how do you break it up? How much is in this episode versus that episode of sleep, and what the timing of it, all of it is. And that becomes a little bit individual based on your specific schedule and the reasons why you can't get 8 hours overnight and that kind of stuff. There is some very good experimental data where they looked at, this came out of David Dinge's lab, they looked at 8 hours of sleep during the day versus 0 hours at night, 7 versus 1, 6, 2, can't get my working memory going now, 5, 3, 4, 4, right? And essentially what that study showed is that the more sleep that is in the overnight period, the better the next day performance, even though they were controlling for 24 hours sleep. And that kind of argued against the polyphasic sleep trend at the time. But I think the reality is it better to only get 4 hours at night because that's all you can do, or is it better to get 4 hours at night and 4 during the day? It's probably better to get 4 and 4 than only 4 at night. But ideally, if you can get all 8 at night, you get all 8 at night. But I think there's real issues around the timing of sleep once you start to break it up. Sean.
Sean, we wrote a review on polyphasic sleep for the National Sleep Foundation, and the first author is Weaver, and so W-E-A-V-E-R, and his initials are M-D, and I'm one of the authors, and it was because of this trend for people to, I completely agree with Sean that if you can't get consolidated sleep because of shift work and so on, polyphasic sleep is a good second option. But there was a trend in internet blogs and everything for people to be promoting polyphasic sleep in place of, consolidated main sleep overnight. And so we wrote this review to talk about the adverse effects of polyphasic sleep. So it's published in Sleep Health in 2021.
Why don't you just send that to Aakansha and let her send it out to
sure.
everybody. Okay, so any of these rules that folks are curious about?
Do not go to bed hungry or too full.
Don't go to bed too hungry or too full. Yeah, so that becomes a sort of comfort issue, right? If you are hungry and so your stomach is growling and you have discomfort in your stomach, it's going to be harder to relax and fall asleep. Same thing if you're too full. If you're too full and you're bloated and you're uncomfortable, then it's going to be hard to fall asleep. There is, I'm sure as folks know, there's sort of a shift in the ratio of sympathetic to parasympathetic nervous system in sleep versus wake. And there's some implications in that for digestion and how well you can metabolize and utilize the nutrition that you've been eating. But that isn't really the issue from a sleep quality perspective. The sleep quality perspective is really just one of comfort. And so often what we'll talk to people about doing, especially like in our hypothetical case where the person has to stay up till 1 o'clock in the morning, hunger will actually start to build if they're normally going to bed at 10. They may get some hunger between 10 p.m. and 1 a.m. because of the impact of circadian rhythms and sleep deprivation on leptin and ghrelin. Ghrelin goes up, leptin goes down. Naturally, it leads to more appetite. And so we'll talk to people about eating a small snack, small non-high calorie sort of snack in that in-between window so they're not going to bed too hungry. But you don't want to eat a full meal because then you'll go to bed too full. And that leads to the sort of old idea that if you eat something with tryptophan in it, whole milk, lots of white meat, if you eat something with a lot of tryptophan in it, it will help you fall asleep because the tryptophan gets converted to serotonin in the brain. Serotonin is related to sleep onset. Turns out, though, that's not actually true. And the reason for that is that tryptophan competes, so tryptophan's an essential amino acid, right? And in order to get from your food to serotonin, it has to cross the blood-brain barrier. Well, tryptophan competes with all the other essential amino acids to cross the blood-brain barrier, and tryptophan is the weak little sister. So it is the worst competitor to basically jump on the transporters that get across the blood-brain barrier. So all the other amino acids will get through, and tryptophan won't. So if you eat a complete protein, which dairy and meat and that sort of stuff would be a complete protein, has all the other amino acids in it, tryptophan doesn't actually very successfully get into the brain to get converted into serotonin. So that sort of idea that has been around for a while that eating one of these snacks helps sleep doesn't really work.
Though if you believe it does, it probably does, right? So if you've been drinking warm milk every night and you associate it with falling asleep, that mechanism may work just fine for you.
Yes, because then you've got a conditioned response, right?
Yeah.
So the thing that Greg brings up is interesting. There is a larger placebo effect in sleep than almost any other field of medicine or psychiatry. It's unbelievably big. And so yes, in that particular case, the placebo effect effectively, or the condition, to be more generous and say it's a conditioned, classically conditioned response, can be helpful, yeah. Any others of these? Yeah. So there's no particular food that promotes sleep. There would be food that promotes non-sleep. That was terrible grammar. Promotes an inability to fall asleep, right? So you don't want something with caffeine. It wouldn't be a good idea to eat chocolate. And you don't want something with lots of sugar because that sort of increases, right? But otherwise, something relatively small. Now, we've heard about the metabolic problems that occur during sleep loss and with out-of-phase eating and circadian rhythms. And so you wouldn't want something that is high fat, high sugar, because you get a poor metabolic response to that. But you know, if you're eating a tiny little thing, as opposed to a whole meal, the metabolic response probably isn't going to be that disadvantageous. But yeah, so essentially, kind of anything that isn't going to promote wakefulness is probably relatively safe if you're doing it in small amounts.
So, like recently in the corporates like Google, they are started providing the nap pods or some specific room designated to take a nap for their employees. So why is that? Like it might not come under the sleep time.
Yeah, that's a really good question, right? So, and there's different philosophies on napping. There are some people, Sarah Bendick being one of them, who was my postdoc a long time ago, that are huge proponents of napping, right? And they think napping is good all the time for everybody. I'm definitely not in that camp. I think if you have to nap during the day, it means you're not getting enough quantity or quality of sleep at night. And so the big corporations like Google that are providing napping pods and stuff like that are acknowledging that their employees aren't getting sufficient sleep at night. And so it's better to let them nap during the day and recover a little bit and be productive in the afternoon than have to just have their performance drop all day long. Right? But the thing that would be better is if they set the conditions so they could sleep good at night. Yep, watch this. So this is what I was talking about a little bit earlier. Watching the clock tends to make people more anxious because they either think, okay, it's been 10 minutes, I haven't fallen asleep. It's been 20 minutes and I haven't fallen asleep. I really need to fall asleep. It's been a half an hour and I haven't fallen asleep. Or they wake up in the middle of the night and they look at the clock and they think, oh my gosh, I've only been asleep for 2 hours. This is terrible. Or I've only got 2 more hours before my alarm goes off. So now I have to try really hard to get back to sleep. And it actually generally creates more anxiety, which then disrupts sleep, as opposed to helping somebody relax and fall asleep more easily. And when I talk to clients about this, and this is part of the cognitive part of CBTI, a lot of clients are clock watchers. And they're like, yeah, but you know, when I wake up, I want to know how much more time I have to sleep, so that I can get enough sleep at night or whatever. And I basically just ask them, look, if you wake up at midnight, would you rather be awake or asleep? And usually they say asleep. If you wake up at 1:30 in the morning, would you rather be awake or asleep? I'd rather be asleep. If you wake up at 5:45 in the morning, would you rather be awake or asleep? Well, I'd rather be asleep. So there's really no point in knowing what time it is, because no matter what time it is, you'd rather be asleep. And simply knowing that you're not asleep and knowing when, either that it hasn't been very long into the night or that you don't have very long left, all that's going to do is create anxiety and make the problem worse. So there's kind of no point whatsoever in knowing what time it is in the middle of the night.
Actually, what's happening in practical, when we are in bed, lots of things are popping in our mind.
That's correct.
So, and that causes very few person can control it. Because if you control your thought, it comes from the you.
Yes.
Meditation.
Yes, I was going to argue. I think people can control their thoughts, actually.
So if I don't see my clock, that it has been 1 hour. So it may induce the sleep also.
It may induce the sleep?
Yeah, because it's too late. What I'm thinking is too late, and at the time I should sleep at that time. So, what's your explanation on this?
Well, I mean, I think right, there will be somebody out there who looks at the clock and thinks, oh, I've got 6 more hours, I have plenty of time to sleep, I can relax and fall back to sleep. That'll happen, sure. But people with insomnia who have clinically relevant sleep problems, they're much more likely to have this anxiety response than they are a calming response. And so I would rather teach somebody how to quiet their mind away from rumination, to let them relax and fall asleep, than have them look at the clock. There's just, in insomnia, there's way more harm than good that can happen by looking at the clock every day. But that isn't to say there aren't specific individuals who are okay looking at the clock. Yes.
There was this point that alcohol before you go to your alcohol consumption, and we've already had a discussion on this before.
Yes.
But is there a rule of thumb that it is okay if it's still 2 hours, 3 hours before bed? Or
Yeah, so the rule of thumb would be if you stop drinking in a sufficient amount of time that you'll metabolize the alcohol you drank before bedtime, then you should be fairly safe. So if you have 3 drinks, you'd want to stop roughly 3 hours before you go to bed.
but I mean, it's coming to mind. There's generally people what they do, they just take alcohol, they just crash.
Yes, that's right.
Yeah, and maybe because of the large amount of alcohol intake that is already done, your body's not able to take it and you must crash. But that is going to, what consequences is it going to have on your sleep quality?
Did you not hear my lecture?
No, I did. I was there, but I'm still just wondering.
Yeah, I mean, essentially what the alcohol does is leads to, after all that alcohol is metabolized, you end up with very fragmented sleep, so you wake up a lot, fall back asleep, and very shallow sleep, so you don't get, you basically hover around stage 1, stage 2, and you don't get the deep sleep. And you'll also often get a lot of REM sleep, which could be good, bad, or neutral, depending. But the big thing is sleep is very fragmented, so you wake up a lot, and it's very shallow. And the other thing, you sort of mentioned drinking so much until you just sort of crash and fall asleep. Sometimes that's late at night, but for sometimes people drink so much in the afternoon, say, they fall asleep really early. And that then burns off lots of their sleep debt, so that not only is that night disrupted by the alcohol, but they burned off so much sleep debt that the next night, they don't have enough sleep debt to fall asleep, and the next night is disrupted as well. So it can sort of have these domino effects.
Did you sleep better tonight?
Last night?
Last night.
I slept fine last night.
So the question is, I think the quality of level also matters.
I don't know that the data would back that up, to be honest with you.
That's why it's called old monk.
I think that I was wise enough to stop drinking a couple hours before I went to bed, and so I had metabolized all the alcohol, and it was good. Good.
There was a point where caffeine intake.
Yes.
12
So caffeine can affect your sleep for up to 8 to 10 hours after you drink it, which is way longer than the sort of alerting psychoactive properties, right? So that's why, again, particularly in insomnia, we have people just cut way back. Ideally, you'd want it at least 10 hours before bedtime. It's sort of easier just to say stop drinking at noon, or don't drink after lunch, or something like that, so that it's 8 to 10 hours. They stop drinking caffeine 8 to 10 hours before bedtime. With that said, there is a caveat that there is an allele of the adenosine receptor that some people have that renders them relatively insensitive to the alerting effects of caffeine. And those folks could drink caffeine very close to bedtime, and it won't really affect them. That same polymorphism actually also impacts slow-wave sleep, as it turns out. So it has a couple of different consequences. But there is a group of people out there who have this polymorphism where they're just not sensitive to caffeine. But they won't be sensitive to caffeine at any point in time during the day, not just in sleep. But for those of us who are sensitive to caffeine, it can affect our sleep for 8 to 10 hours.
So what effect does it make on slow wave sleep?
That polymorphism decreases slow wave power. So they have less overall slow wave sleep, right? So slow wave power is a function of the amount of slow wave and the amplitude of the slow waves. It's area under the curve, oversimplified a little bit. And slow wave power goes down in this polymorphism. So they either don't have as much slow wave sleep, or the amplitude of the waves aren't as high, it's not as intense, whatever. But it's basically going to be less restorative sleep. Just that, like, as a trade level. Hold on, let me go back here and then I'll come back.
Do you have time? Because it's time.
I got nothing but time.
Okay. So I was just wondering.
We have up to 13:45.
So is there any other reason except for the urine bilge for having non-accessibility? Because liquids are supposed to take down your core temperature.
Yeah, it's the urine. It's the urine.
Only the urine.
Yeah. So when you're over 50 like me, you got to be really careful about this sort of thing. When I was younger, it didn't matter. Now it does.
Do you think it is 50 plus?
I appreciate the compliment, thank you very much. I wasn't fishing for that, I swear. But yes. Any others? This is the other one that's helpful to think about. This is what people try to do when they can't sleep. They often lie in bed trying desperately to fall asleep, right? But that essentially leads to this anxiety, psychological performance anxiety sort of response. They're trying so hard, right? And so there's this old, I will not often reflect something from the psychodynamic perspective, but there is an old psychodynamic perspective that says there's only two things we fall into in life: love and sleep. So you can't try to do either one of those. And some cultures have this weird thing about falling pregnant, which I totally don't get, because you don't fall pregnant accidentally. But anyway, the psychodynamic perspective was love and sleep. And so you can't try to fall asleep. It makes it worse. And in fact, an old intervention that has some efficacy data, it's not great, but it does have some efficacy data, was called paradoxical intention. And the instruction was, lie in bed in the dark all night long and don't fall asleep. That's the trick. Don't fall asleep. Just lie there awake all night long. And what it does is it reduces the performance anxiety of trying to fall asleep. And obviously what happens is the person gets sleep deprived, they build enough sleep debt, and they fall asleep. But it's reducing that anxiety around it was the goal of paradoxical intention. Yes?
So there are light sleepers and there are dumb sleepers. Like this is that they have since the very beginning of their life.
Yes, there's light sleepers and deep sleepers. That is true.
And so like the light sleepers, they are fine sleepers, but the external things like the sound and the light, all these things affect them more. So how do you do all this for these light sleepers? Because they think they have to. It's a very big one.
Yeah, it's a good point, right? So light sleepers, someone who's just from childhood has been a light sleeper. And they're a little more sensitive to noise and light or whatever it is. Yeah. So the beauty of the sleep restriction therapy is that it builds sleep debt so much. It basically makes those people sleep deeper. So it sort of increases sleep debt enough that then they fall asleep or stay asleep, and their sleep is actually deeper than it was before they developed sleep problems.
This can be same like
so I don't know if data that people have specifically tried to look at that, to be honest. So I don't know. I mean, what we do know is that being a self-reported light sleeper does not negatively impact. That's the best I can say from a data perspective.
Sean.
Yes.
A quick question. Have people done dose-response study on alcohol and sleep? The reason why I'm asking you is alcohol metabolism follows a zero-order kinetics, right? So most drugs, if you take a higher concentration, you have a half-life. You can estimate the time taken to reach the concentration they have. But for alcohol, it's not. Once it's zero order, it doesn't matter how much it is, the churn through slowly. So normally when it comes to the aldehyde concentration, when you take low, alcohol behaves as if it's a different drug. Then when you take high, because the aldehyde is the problem, right? It attaches to various protein and causes problems. So have people done effect of low level, so to speak, a very small range versus a really high dose?
I'm sure the answer to that is yes, but I don't know the data.
And the reason is because, again, if you speak to these, the cardiovascular people, the only thing for which there is decent evidence, I'm sure from the Verma, low-level alcohol is cardioprotective and it increases lifespan, and it's anti-anxiety as well. So, but they don't prescribe because everybody ends up being alcoholic.
Right.
Liters.
Well, I mean, if you have a drink close to bedtime, that's not really going to disrupt your sleep.
Yeah.
Right? You've got to get. I mean, the data is there to suggest you've got to get your blood alcohol up to around 0.04, 0.05 before it really starts to have sleep disruptive effects.
Yeah. So there must be some kind of a dose response.
Yeah,
right?
you're right.
Very small amount.
Yeah.
So that you can still have a same conversation and feel just relaxed, and maybe it's different than having 2 beers before.
Yeah, no, I think you're right. I'm not quite sure on the data, but I bet you're right. Okay, so let me go to the next one. Oh, yeah.
So that people sometimes they do get first symptom of feeling sleepy, and then they avoid doing some certain work, and maybe they have to study or they have to do some project that completely, and then they know the signal of sleeping first or setting up a sickness or something, and that is why they just don't get this eventually falls to the after towards the down.
Yeah. It's a good question. Yeah, so the question, just so folks can hear it, is that sometimes people will get sort of the body signal that they're sleepy, they'll recognize they're sleepy, but they ignore it for whatever reason. They want to continue to watch that TV show or work on their project or whatever it is. And then by the time they're like, okay, fine, I'll go to bed now. Now they're not as sleepy and they have a hard time falling asleep, and can that contribute to insomnia? It's something that you hear patients with insomnia talk about all the time.
And I would like to correlate to this with another natural phenomenon that we have, that sometimes people ignore signals that in the morning they want to go and freshen up. And if they ignore they want to pass their stools, and if they ignore those signals, they end up getting constipated. Right? This can be a simpler sleep. So they're actually ignoring their first few signals to fall asleep. And
So you will hear people with insomnia talk about this all the time, and it becomes part of the cognitive component that they're almost afraid and this becomes a problem with, I can't stay up to 1 o'clock in the morning, because if I become sleepy at 10:30 and I don't go to bed, I'll never fall asleep. Right? Becomes a really common anxiety, and it's not quite true. So what is true is that sleepiness comes in waves. Kind of like hunger will come, even when you haven't eaten a while, hunger will kind of come in waves. You'll get really sleepy and it'll kind of go away. And then you'll get sleepy again later and it'll go away. And so what you have to sort of do, it is true that if you miss that first wave, then it might become objectively a little bit harder to fall asleep in between the waves. But a wave of sleepiness will come back. It's not true that it means I didn't fall asleep at 10:30, I'm never going to fall asleep tonight. Right? But it does kind of come in the waves. But I don't know of any data that would suggest somebody who systematically ignores the first wave is more likely to develop insomnia. I haven't seen any data like it, because it becomes, at that point, it becomes about the cognitive response to missing the wave. And if someone is calm and relaxed and doesn't care, they're not going to develop insomnia. Someone who becomes anxious about it and feels like I'll never fall asleep, they're more likely to develop insomnia.
you're talking about sleep restriction, right? And the wave came maybe at 12 o'clock and he's supposed to sleep at 1. It came at 10, it came at 12, but now he's supposed to go to sleep at 1.
And there'll be another wave of sleepiness and they'll be able to fall asleep. The waves don't stop coming. That's the whole point of homeostatic pressure, right? They just don't.
So we don't advise them to fall asleep at that sleepiness right comes.
Nope. If you go to sleep early in sleep restriction, you're actually working against the whole rationale, because you are not building a sufficient amount of sleep debt to fall asleep and stay asleep all night. Yeah. Jim? Yeah, so the timing of exercise, that's actually in one of my subsequent slides. Let me see if this is not on there. But so the timing of exercise, essentially, I was talking earlier about how being in very good cardiovascular condition, being a regular exercise, helps you sleep better overall. the deal with exercise is you want to stop exercising far enough away from bedtime that your heart rate comes back down to baseline. And so how long that is will depend on how good of a shape you're in, right? Someone who's a marathon runner and they're awesome cardiovascular condition, their heart rate comes down very quickly. People who are in not as good of a shape, their heart rate comes down much slower. And the interesting thing is, our heart rate, we will subjectively feel like our heart rate is normal before it actually is. And so you want to talk to somebody, if they think, oh, it takes me 30 minutes for my heart rate to normalize, you probably want that person to stop exercising an hour before bed, because it takes a little bit longer than what we think it takes for our heart rate to normalize. But that's the issue with exercising. The other thing with exercising, particularly from a treatment perspective, exercising is one of those Zeitgebers that somebody was talking about, the net of the spider web of Zeitgebers. I can't remember the term they use, right? But there's a whole series of Zeitgebers. Exercise is one of them. And so if you can exercise in the morning, that helps to reset and regularize and train the circadian rhythms. As well as, like Greg was talking about, social interaction is another Zeitgeber. That's why it's part of social rhythm therapy. Light is obviously the big Zeitgeber. So one of the things that we talk to people about in the morning, if you can get up at the exact same time, go outside, get sunlight, exercise with a friend, come home and eat breakfast at the same time every day, you've gotten basically every Zeitgeber that we need in order to entrain our system. And so from a treatment perspective, it's better to exercise in the morning than nothing. But if you're going to exercise in the evening, you want to have that buffer before bedtime. So one of these that I want to talk about, because I was talking about with someone at the break about it, is the bedtime ritual. And developing a bedtime ritual can be a really important part of healthy sleep onset, right? So how many people in here would say you have a bedtime ritual?
What is that bedtime ritual?
Very good question. A bedtime ritual is any, fair enough. A bedtime ritual is any basically set of consistent behaviors that you do that signal to the brain it's time to go to sleep. So for example, my bedtime ritual is very simple. I brush my teeth, I wash my face, I put on my pajamas, and I get in bed. I'm a good sleeper, that's all I need, right? Other people will have much more elaborate bedtime rituals that they do. And so you might have listening to the podcast for an hour to help you relax, or reading, doing meditation or prayer, or something like that before bedtime that basically helps you wind down. It helps you physically wind down. It helps you psychologically slow your brain down. It helps distract you away from the stressors and worries of your day. Those are the kinds of things that constitute a bedtime ritual. And the specific behavior that makes a ritual is as varied as there are people in this room, right? But developing that bedtime ritual is a really good way, right? If you think of conditioned arousal as I'm in bed, I'm awake, and that's the stimulus. Part of breaking that could be developing this bedtime ritual so that the conditioning doesn't start right here, it starts way back here, right? I put on my pajamas, and I do some meditation, and I read, and I listen to my podcast, and I drink my warm milk. You've got all of these associations then that are building to say, now it's time for my brain to relax and fall asleep. That can be a really important part of developing a healthy sleep routine. And again, like, I'm a very good sleeper, so I don't need all of the sort of elaborate conditioning. I brush my teeth, close my eyes, and go to sleep. People who have insomnia don't find it that easy, right? And so helping to build this ritual in can help to create the conditioned environment for them to fall asleep more easily. We've had a little bit of this too, getting your body to the right temperature, right? So we've already heard a lot this week about the circadian rhythm, and the core body temperature rhythm is one of those things that is circadianly driven. Core body temperature, roughly speaking, is at a peak a couple of hours before habitual bedtime, assuming we have a regular bedtime. Somebody showed sort of the much more nuanced temperature graph where it kind of goes up and it's flat a bit during the day. But if you looked at that graph, what you noticed is a couple hours before bedtime, there's a little peak. The body temperature goes up. And one of the things that we have found, right, and so you would think if body temperature peaks 2 hours before bedtime, it's still pretty high at bedtime. And so now you're thinking, well, wait a minute, we're supposed to have a low body temperature to fall asleep, yet we typically, healthy sleepers, fall asleep while body temperature is relatively high for the 24-hour cycle. Right? Why is that? It's because one of the signals to the brain to start to get sleepy is the slope going down. So not necessarily the absolute temperature, which is important, but the slope, the descending slope of the body temperature curve sends signals to the brain that it's time to wind down and go to sleep. So one of the things, this is why you will have heard maybe take a hot bed, right, or get in a nice warm jacuzzi, artificially raise your body temperature an hour or two before bed, and then that slope drop becomes more steep. And that sends a stronger signal to, excuse me, to the brain to fall asleep. It was, in theory, one of the things behind drinking warm milk before you go to bed. There's the tryptophan, but then there's the raise your body temperature. But I think you'd have to drink a lot of extraordinarily hot milk to actually raise your core body temperature. So that probably isn't the mechanism. The other interesting thing about this is, we were talking about this earlier, in order for your body temperature to get down, you have to lose body heat, right? We lose body heat primarily from our hands, our feet, and our forehead. So that's where we need to sort of lose all the heat from. So this is why, and this has been proven scientifically by Anna Verts-Justus in Switzerland, having cold feet, it's harder to fall asleep.
Yeah, that's what I was alluding to.
Yep. Having cold sleep makes it hard. Cold feet makes it harder to fall asleep because you're not losing as much heat from the periphery of your feet when they're cold. So Anna Verts-Justus did this very cool experiment in Switzerland, right? Very cool place, where she brought them in and she had people sleep barefoot, where their feet would be really cold, and then she gave them socks with batteries in them that made them stay really warm all night. And she found that the people with the really warm battery-driven socks fell asleep faster, right? I mean, it's pretty logical when you think about it, but it's one of those really cool experiments that I kind of, I wish I had done, because it's just this interesting little thing. And so it's, lots of us will complain that it's hard to fall asleep with cold feet, and it's now, well, a long time ago, was scientifically proven without a doubt to be true.
What's the effect of doing workout during the evening time?
Say again?
What's the effect of doing workout?
Workout in the evening times. You must have been taking a nap when I just answered that question. So you want to, so working out is good because it raises the core body temperature, but you want to finish the workout in sufficient time that your heart rate has normalized before you try to fall asleep. That's the key.
You said battery, the socks were made longer because of batteries. How do you lose the heat on the feet?
Because it's a good question. It basically dilates the blood vessels, right, the capillaries and stuff, and that lets the heat out. Even when the socks themselves are warm, it still lets the heat out. So that's why when you put, you will lose body heat in terms of your core body temperature coming down, right? Because you got to remember, the circadian system is also trying to lower body temperature at that same time, right? And so it's, I get where you're coming from, because it's a little counterintuitive. You would think it would prevent you from losing heat. But because it dilates the capillaries, that lets the heat out. And I'm not a physiologist, so yeah, I can't. I'm not being a physiologist. I can't give you the best answer, but.
So should we make a difference between the surface body temperature and cold body temperature?
Yes, it's not the same. You want core body temperature going down. And that might actually lead to some of the periphery being a little bit warmer because you're losing heat. And so the surface of the
warm surface but cold.
Warm periphery, cold core. That's what you want. That's right. Shanta, yeah, go ahead.
That work Sean was building on a whole lot of work that Anna Verts-Justus had done, where she looked at the relationship between core temperature and peripheral temperature at sleep initiation. So exactly as you described, she found that there is this inverse relationship with peripheral temperature increasing as core temperature decreased. And therefore she came up with the hypothesis that if you increase peripheral temperature, you are promoting peripheral vasodilation and so on to enhanced the core temperature coming down, and that's what she found. So it was building on that argument that there is this, the ratio of peripheral and peripheral and core temperature is what is going to drive sleep initiation.
That's what a blanket is doing, I guess.
That is what?
A blanket is doing.
Yes. I mean, you're trying to warm as much as possible the extremities. Yeah. Which is a little difficult in the when it's a warm climate, but you've got to work out how to do that. Yeah.
So then the last set of sleep hygiene rules, right? So we've been, basically the sleep hygiene rules we've been talking about are to help sleep at night. The last set is the other part of our circadian rhythm, which is you want to make sure you're awake and alert during the day. Because if you're falling asleep during the day, you're burning off your sleep debt, you're going to make it harder to sleep at night, right? And so we've talked a bunch about bright light already this week. We've talked about exercise this morning a bunch. And then I have the strategic use of caffeine, because as we talked about a little bit ago, you don't want to use caffeine too close to bedtime, because for most of us, that will interfere with the ability to fall asleep. But you do want to strategically use caffeine, and particularly during sleep restriction, when you know the person is going to be extra sleepy during the day, and that might have performance problems, it might be risky if they're driving, you want to strategically use it in order to help keep them awake during those times when they really need to be awake and functioning for whatever reason. Okay, so that's all of the sleep hygiene stuff that I wanted to talk about. Before I move into the next thing, which is stress reduction, relaxation, any other questions on sleep hygiene?
You said that when for treating it, when we are giving a CPG to insomnia, we are trying to ask them to stay awake up to 1 o'clock and then basically to fit them in a restricted sleep.
Yep.
At that time, when a person is trying, kind of struggling, that okay, I don't have to go to sleep up to 1. Yes, if I give you caffeine to that person, will that?
No, because if you give them caffeine at 10:30 to help keep them awake till 1, it'll still be interfering with their sleep at 1 o'clock. Right? And so you set them up to have a hard time falling asleep. Now, if they can't fall asleep till 1, you can back that down, to 8 to 10 hours before that, so they can have caffeine pretty late in the afternoon, but not at 10:30 or 11 at night. Yeah.
Sean, all these questions when these people are asking, they are completely ignoring the circadian rhythm contribution to sleep. Because all of the stimulus, some of them for sure tend to disrupt or delay or cause the phase shift in the underlying circadian rhythm, which does contribute even if little to the timing of the sleep.
Yeah, no, absolutely. And that's one of the reasons why,
during the late 70s, and early 80s, Berturek and others, Ivan Contor and others, they were just demonstrated that morphine or benzodiazepine or carbachol or whatever, they also have a basic effects on the underlying circadian. So although homeostatic drive is cool, it's a large part of sleep, but as far as the timing of sleep is concerned, these can also phase shift. So
yes.
Never try a agent which affects your circadian clock to phase, to delay or build up the sleep debt.
Yeah.
Try some other method.
Yes, that's a really good point. Thank you. And I tend to underemphasize the circadian component when I lecture about it. Totally true.
One question from my side.
Please.
The blue light and sleep.
Yes. So that's a.
Because the investors lose a lot blue light.
Yeah. All the electronics are going to get the blue light, right? And so I think we heard earlier in the week about the most electronics these days have a night mode that will filter out the blue light, which has been shown to. They have been shown to be effective in filtering out the blue light. There haven't been as many studies to show that filtering out the blue light in that way reverses the sleep interfering effect of the electronics. That data, I imagine it's true, but the data is just, unless Shantha would say otherwise, I don't think that data is there. But the other problem with the electronics, in addition to the blue light, is what it does to the brain. right? And then it ends up, particularly if you look at social media or something, it'll often wind you up, and then it's that cognitive activity that makes it hard to fall asleep.
So watching TV, mobile, social media, etc. before sleep, it is advised that shut off everything 3 hours
Yeah.
before sleep.
So TV is interesting in that if it's far enough away, the blue light isn't gonna, am I right about this? The blue light's not gonna interfere if it's sort of across the room from you, right? But if it's right here in your face, it's gonna interfere. Yeah. Okay, so yes.
Any relationship with, between dehydration and sleep?
I would imagine the answer is yes, but I don't know those data. I mean, I would think if you were dehydrated, it would be harder to sleep.
Water intake and sleep.
Yeah, well, so the only issue with water intake, as we were talking about earlier, is it makes you have to get up and go to the bathroom in the middle of the night, right? So you have to sort of make sure you're not drinking so much that that interferes with your sleep. But I would suspect that that dehydration would make it harder to sleep. I don't know for sure, but I would suspect it does.
Because dehydration and headaches have.
Well, the headaches for sure are going to interfere with your sleep. Yeah, absolutely. Yeah. Yes, it certainly could be. It certainly could be. All right.
My question is about the light and the sleep. So I think you all are attending, like last week, we were discussing about when the light used in the evening hours to fall asleep.
Yep.
So for a person like in a nursing home or somewhere where you don't have this nutrition certificate with the lights, do you recommend the special classes?
Yeah, well.
Will you ask them to wear these glasses in the evening?
Yeah, it's a great question, right? So we've talked a lot this week about wanting to dim light close to bedtime so you don't phase delay, you let melatonin turn on. And if you're in an environment where you can't control the light, like you might be in a nursing home, then yes, actually wearing those glasses would be a good alternative to block the blue light. Now, I think as Shanta was talking about, it's not just the color of the light, but a really intense non-blue light will still interfere with your circadian rhythms. But it would be a good step to take to get those blue light blocking glasses if you're in an environment where you can't change the light.
Blue light blocking glasses or what you have some other glasses?
Blue light is the key. I mean, when you say blue light's the key to block. Yeah.
Pigment is sensitive, circadian pigment is sensitive. Or green light.
Okay, so if I talk about we're good on time, right?
Yeah.
So the other component, the next component of CBT for insomnia that I want to talk about is this sort of stress reduction relaxation component, right? I talked a bunch already, it keeps coming up, about how much anxiety and stress is part of the clinical picture in insomnia, both in terms of precipitating and in terms of perpetuating the insomnia. And this is true even in people who don't have a diagnosable anxiety disorder. Right? The stress and the anxiety just sort of becomes, and the physiological arousal, right? Conditioned arousal, part of that is not just psychological, it's physiological as well. And so it's often the case that we put a stress reduction component in there because not only is there all this stress and arousal right around bedtime, but there's really good data from kind of day-to-day longitudinal studies, like EMA sorts of studies, that show higher stress levels during the day, even well independent of the sleep timing. Stress levels during the day disrupt and make it harder to sleep at night. Disrupted sleep at night basically increases stress levels the next day, and so you get in this positive feedback loop very quickly. And the same is true with negative affect. That negative affect during the day leads to sleep disruption at night. Sleep disruption at night leads to more negative affect during the day, and you sort of get in this feedback loop. And so it can be a helpful adjunct to reduce negative affect and reduce just overall stress during the day. The other piece of this is there's a scale called the pre-sleep arousal scale, which looks specifically at cognitive and somatic arousal around bedtime. And there's pretty good data showing that people who are high on this measure of pre-sleep arousal have much more sleep onset problems, which just again just sort of reinforces this idea of arousal and stress be it physiological or cognitive or emotional arousal, interferes with sleep. And so essentially what we do in CBTI is we teach people relaxation, stress management sorts of techniques. And pretty much any technique that the person is willing to learn that is a stress reduction sort of technique is helpful. So the classic ones that have sort of been around forever and show up in a lot of the CBTI manuals would be things like diaphragmatic breathing, visualization exercises, visualize yourself walking on a sandy, warm beach and with the relaxing breeze, blah, blah, blah. And progressive muscle relaxation is the other sort of old classic one. But it doesn't matter what you do. So I was talking, I think the other day, a little bit about mindfulness-based therapy for insomnia that Jason Ong sort of took out of mindfulness-based stress reduction, which came out of transcendental meditation, sort of brought that into sleep. Any of those sorts of techniques that essentially reduce physiological and cognitive arousal can be helpful in this context. And so, again, any of those sort of meditations, prayers, yoga, basically anything that leads to this de-escalation, or this de-arousal, I should say, can be helpful. And what we typically try to do is get folks to realize you need to reduce stress levels during the day, not just immediately pre-sleep. So you want to be using these exercises throughout the course of the day, not just in the 10 minutes before you fall asleep. And in fact, if you talk to a lot of mindfulness practitioners, they'll argue, you guys probably know this, they'll argue that most mindfulness isn't meant to actually put you to sleep. Mindfulness is meant to be sort of very aware and conscious of where you are and who you are and what your surroundings are. And so it's not meant to put you to sleep. Although there are, I just learned this week, there are specific yogas that are apparently intended to help promote sleep. And so, but regardless, I digress a little bit. The point is, you want people to be reducing stress levels during the day as well as at night. And so this is the kind of thing that we typically try to schedule in 1, 2, 3 times a day, whatever the person can tolerate doing, even for very short bouts. Because again, the longitudinal data shows us that high levels of stress during the day lead to sleep disruption at night, and that lower levels of stress during the day facilitates better sleep at night. So we just need to reduce it in whatever way, like what I tell when I'm training clinicians, essentially I say whatever technique you're comfortable teaching and they're comfortable learning, that's the one you want to use. It really doesn't, there's no data to suggest that any one is better than another. Questions, comments on that?
That's why I'm saying that Prof may be a factor to use the stress. But watching the clock at night, and what I have done was the whole day, and at the bedtime, I'm thinking the process that what I have done in the night. And then I saw the clock, it's 11, and it's time to sleep. So my stress will go down.
Yep.
So by watching the clock at the night may induce the stress, also may induce stress reduction and sleep.
Yeah, so essentially what you're arguing is that for you, looking at the clock and seeing its bedtime, essentially, is part of your bedtime ritual that helps you to relax and unwind and go to sleep. I don't at all deny that is true, and that there's others out there who have the same experience. What I was arguing earlier is that in the context of insomnia, watching the clock generally creates more problems for those individuals than it helps. But I'm not at all denying that there are folks like you out there that looking at the clock in the evening and seeing what time it is part of this winding down ritual that they use that's very healthy. Those two things are not inconsistent with one another. They can both exist in different people.
So depends on the different kinds of people.
Totally depends on the person. Absolutely. Yep. Did you have something? What about it? Yeah, so pre-sleep arousal is Essentially, it is being cognitively or somatically, physically, alert and aroused prior to bedtime. And so the pre-sleep arousal scale is a self-report measure, right? And the cognitive side asks a lot about rumination and having a hard time turning your brain off and your thoughts racing and things like that. The somatic arousal refers to tension in the muscles, having an elevated heart rate, having a fast, shallow breathing, things like that that would be associated with physical arousal, not exactly panic, but sort of down that line kind of response. So it's related to this conditioned arousal, right? You're both physically and cognitively alert and aroused, hypervigilant, if you will. That's what pre-sleep arousal is. And a subset of patients with insomnia will have very severe pre-sleep arousal. And in those cases, it's very important to teach them some sort of relaxation technique as part of their bedtime ritual so you can dial back that pre-sleep arousal. Because there's very strong correlations between high pre-sleep arousal and poor sleep.
Would not be good sample of pre-sleep arousal is phoning, excessive phoning before prior 2 hours. So for whole life, I normally don't phone anyone. Nor I try to receive a call after 10. Like my sleeping time is 11. It used to be 10. Now it is 11 to 6 or 7. And when I used to have dart phone, 10 o'clock, I'll remove the dart phone because nothing is going to fall. I'm not going to come from Prime Minister tonight or even day. Nothing is important. And that's what the whole system, our system was: do little prayer, be happy, Those things are very small. I said, it's a ritual. If we adopt it, that I'll not phone anyone, because if you don't phone, you don't interact. If you don't interact, there is no question of argument. I never had argument with my spouse. Why should you have an argument before? But many people unload everything at night. And I had this condition. After I come from university, I usually used to go to take shower. And you have to tell me anything of the day before I take the shower. If I have taken the shower, I'll eat. Then it's my time whether I watch whatever I do. And not listen any complaint, anything. Keep it for tomorrow. But now when the both work, they unload on each other, keep on suggesting. You should have said this, Professor Verma, you should have said this. And he said, well, you should have said this. And then you are aroused.
That's right. Yep. That's a very good example.
You don't, in our situation, there is a lot of unnecessary interaction, which has nothing to do with the spousal interaction. Outside word is influencing you. Whatever has it. Once you enter, because my wife is not academician, I never talk anything of academics in my house. I'm only husband, I'm only father, not husband. So if you small distance, because your people's life is going to be a little difficult. So, one thing you do, 2 hours is for my Lord, whatever you want. And you see, your insomnia might get better, if you have any.
It's a good example of developing a solid bedtime ritual.
Yeah.
Okay, so again, going back to we do stress reduction essentially to deal with a lot of the perpetuating factors, the things that keep going in the insomnia going, the stress and the hyperarousal and all that kind of jazz. Just a couple more ones to get through. We've got time, 10 minutes, 15 minutes. So
there's a lot of time before lunch.
There is a cognitive component to cognitive behavioral therapy for insomnia. That's why the C is there. People do different amounts. As a clinician, I tend to do very little C and lots of B, lots of the behavioral stuff, which is what I've been talking about all day. Other people, Allison Harvey, for example, does a whole lot of cognitive therapy. and less behavioral therapy. So you can sort of, depending on your style, you can do it a little bit differently. But there's a couple of tenets to the cognitive component. The first is that there's a lot of myths around sleep that people have that lead to performance anxiety about the sleep and lead to stress associated with the sleep, right? So one of them is everybody has to get 8 hours of sleep. Frankly, that myth is our fault as a field because we said that for decades. Turns out that that's not true, shockingly. There's a normal curve in terms of sleep need. The big fat part of the curve is between 7 and 9 hours, so most people need somewhere in there. There are some people who can get by on less than that. There are some people who need more than that. There's relatively few people who can truly get by on less than 6 hours of sleep. There's far more people who think they can do it. Huh?
He is one up. He requires 4 hours, 3 hours sleep.
I'm willing to believe that.
Very less sleep. Very less sleep.
There is only about 2 or 3% of the population who can actually truly get by on less than 6 hours of sleep. Lots of people who think they can get by on less than that are either performing not at their optimum, and there's this interesting phenomenon. We see it actually, it first came out of sleep apnea from a sleep perspective, but that people will have sleep disruption and sleep deprivation for so long, they think that what they're doing is normal. They think they're performing at a normal, optimal level. But if you actually correct the sleep problem, they get more sleep, they start sleeping better, their performance goes up. And it's this habituation response that you basically redefine normal when you've been underperforming for so long. But so that's one of the myths, and there's lots of other myths. There's a questionnaire called Dysfunctional Beliefs and Attitudes About Sleep, which is a 16-item questionnaire that has a whole bunch of these myths that come in. And one of them, another one is, if I get a bad night of sleep tonight, I'll be completely 100% unable to function tomorrow. So like this black and white thinking, which generally, again, is not true to that extreme. And so there's a whole lot of cognitive therapy techniques that I'm not going to bother to go into, where you can help sort of people to think about their sleep and the consequences of poor sleep differently, and essentially a less stressful, less interfering way. The other thing, and that's sort of what I talked about here. We've already talked about this one. If I don't fall asleep by a certain time, I'll never get to sleep. That has to do with the sleep waves. There's another one that is, I can never predict whether I'm going to get a good night of sleep or a bad night of sleep, right? My sleep is too chaotic, and you heard me talk about that with PTSD the other day. Essentially, we correct that myth by teaching them how to control their sleep so that they can actually very easily predict whether they get a good or bad night of sleep, because it has to do with the sleep drive and all that kind of thing. The other interesting thing, and this came out of Alison Harvey primarily, and it started when she was working with Colin Espy, there's an attention bias towards sleep in people with insomnia and sleep difficulties. So this is parallel to, some people may have heard of the attention bias in depression. When someone is actively depressed, they have an attention bias where they notice, pay attention to, and remember negative things in the environment, things that reflect poorly on them, things that reflect poorly on the future, on other people, right? They basically see all the negative stuff around them and don't process the positive things. In insomnia, it's a sleep-related attention bias, where at night, somebody's paying attention to all the signs that they're not sleeping. I'm lying in bed, I can hear the dog bark, I can hear the kids, I can hear the traffic outside, I can feel my own heart rate. So they're paying attention to all of these signs that they're not sleeping, which then perpetuates the stress and anxiety and makes it harder to sleep. And then during the day, they pay attention to all of the negative consequences of poor sleep. So every little thing that goes wrong, they attribute to the fact, oh, that's because I didn't sleep last night, right? I can't remember where I put my keys, or I can't remember what I was going to say to this person when I walk in the room. It's because I didn't sleep well last night. And they don't think about the fact that there's lots of reasons you might forget where you put your keys. There's lots of reasons you might forget what you're going to say to somebody when you see them later today that have nothing to do with sleep, right? People who are good sleepers forget what they were going to say. And so, but this attention bias helps perpetuate the insomnia because they constantly are gathering evidence that they're a bad sleeper, and they're constantly gathering evidence during the day that they had bad sleep last night. And that just perpetuates the identity of, I'm a bad sleeper. And so there's, again, techniques you use to help sort of unlock people from that thought process and get them to sort of view things a bit differently. So that's the cognitive side of cognitive therapy. And again, in the 4-factor model, just like with basically everything else, we do cognitive therapy to address some of the perpetuating factors. And some people have more of those perpetuating factors than others, and so some people need more cognitive therapy than others. And then finally, there's relapse prevention. And in relapse prevention, essentially is the idea of, there's two things in insomnia. So I talked about insomnia treatment lasts 6 to 8 weeks. Every week, assuming the person has 85% sleep efficiency, we give them 15 extra minutes in bed. So they go from, in our case, 6 hours of sleep to 6:15, 6:30, 6:45, 7 hours of sleep, 7 hours and 15 minutes, 7 hours and 30 minutes. So rarely at the end of 8 weeks is somebody getting exactly the amount of sleep that they want. We get them along the way. We teach them all of these new skills. We get the trajectory going upwards, but they're not necessarily at 8 or 8.5 hours of sleep by the time they're done with us. So the first part of relapse prevention is, how do you take all of these skills you've learned and keep doing it on your own without me holding you accountable? And usually that's pretty easy, because after 6 or 8 weeks of doing this, people really know the skills, they understand what they're doing, they've been practicing it for a long time, so they can kind of keep going. And then you have to decide, when do I stop, right? When do I stop adding 15 minutes to my sleep schedule as my sleep efficiency keeps getting better and better and better? And there's basically a couple of ways to do that. If I point a slide on this now. There's a couple of ways of deciding sort of when you stop doing the titration. And essentially there's 3 ways. One is when you can no longer maintain 85% sleep efficiency, right? So eventually, if you keep adding time and spend more time in bed and more time and more time in bed, your brain's not going to be able to absorb all that extra time, and your sleep efficiency is going to start going down again, right? Which is the original problem. People spend too much time in bed. So when that inflection point happens, you know you've gone a little too far. You have to back up, and then you can stop right there. Right? The other big thing that people use is, when the daytime consequences of having poor sleep are gone, that probably means you're getting enough sleep. When you no longer have to take a nap during the day because you're sleepy, that probably means you're getting enough sleep. So there's a couple different ways of doing it. But then the key is, once you're a good sleeper again, now sort of how do we prevent the insomnia from kicking in the next time you have a stressful event in your life? Right? Because we started way back with the 4-factor model saying the precipitating event that kicked off the insomnia is some sort of stress in life. So how do you help the person prevent the insomnia coming back when the stress comes back? Because the stress will always come back. Right? So there's a couple things. First, you want them to remember that relapse is not one bad night of sleep. Right? We all will have bad nights of sleep every now and then. Even the best sleeper in the world will have some bad nights of sleep, often that are stress-induced. That doesn't mean the person is completely relapsed into insomnia, right? It's normal to not sleep perfectly every night. And so what we tell people is, aim for 5 out of 7 nights of good sleep, right? Or take it even more broadly, right? If you have 6 or 8 bad nights a month, that's actually not a big deal. Right? And you tell someone who's struggled with sleep problems for a long time, it's okay to have 6 or 8 bad nights a month. That's a huge relief to them, because they know, I'm going to have a few bad nights every now and then. No need to stress out if you have 1 night, maybe even 2 nights in a row, no big deal. Right? And again, that reduces the cognitive component that leads to the relapse in insomnia. And I'll get back to that last point in a second. And so then basically the other piece of relapse prevention, and this is true in any sort of psychotherapy, is if the insomnia does come back, if it does happen now, it's not just 1 or 2 days a week, but you're actually noticing 3 or 4 days a week for several weeks in a row, now I'm feeling like, okay, I am getting myself in trouble here, my sleep is getting bad. Essentially what you want to do is have the person start over with the treatment on their own that they've already done with you. Have them fill out a sleep diary, examine the sleep diary, look at their sleep opportunity, look at their sleep ability, self-impose sleep restriction therapy, redo stimulus control, go back to not violating sleep hygiene rules. So basically, You want to help the person realize they have all of the knowledge and skills they need to just do this treatment on their own. Right? I tell my clients, my job is to turn you into your own sleep doctor. So you don't ever need me again. You know all of this stuff, you can do it on your own. And I give them a manual as part of this. I do a very manualized intervention. So they walk away with a manual that has all the instructions in it and has all the notes they've taken in their 2 months with me about what they did and what worked and what didn't work, so they can just do this again on their own. Most people don't get, their insomnia doesn't become that extreme where they basically have to start over from scratch. That's because this is a durable treatment and people's behaviors have changed in such a way that they're not going to have more than a couple bad nights of sleep because they're not engaging in the perpetuating factors that created the insomnia in the first place. Okay. And then finally, it's just really helpful to know, this goes back to my lecture the other day, if the insomnia does come back in a strong way, that could be a sign that something else is going on, that they may relapse into a mental health condition that maybe is coming back, right, assuming any of this was relevant to begin with. But you want them to be thinking about insomnia is a barometer for what's going on in our life, right? Sleep can kind of be the canary in the coal mine. When sleep goes wrong, we need to actually start thinking what else might be going on in my life that I need to address. And this was especially important for me, of course, as a psychologist. When I was in the Veterans Hospital, my clinic was in the psychiatry department. And so almost everybody who came through had mental health issues as well. So this was a really important part of what we did. And with that, and then the final thing is, and this is kind of what I was saying before, if the insomnia does return, you can use 2 mantras: restrict and control, that is, do sleep restriction and do stimulus control, or efficient control. If you're calling sleep restriction sleep efficiency therapy like I do, you would say efficient control. If they can remember those mantras, it helps to cue them in to the behaviors that they need to start doing in order to treat the insomnia on their own. And with that, I've been talking way too much this morning, and so I will stop and end it there. If there's any more final questions, I'm happy to answer them. If your brains are totally dead and you want to move on to the break, I'm totally fine with that as well.
How do you categorize these categories? Like moderate, acute, problems?
How did I categorize them?
Yeah.
Oh, you must have missed the beginning. So I went through all of this model at the very beginning. So you can watch the recording. Or I can tell you offline.
It took like 30 minutes.
Anything else? All right, thank you for your attention.
Whether there is any seasonal variation in sleep?
That's a really good question. So we've actually have a paper published on this in behavioral sleep medicine. So what we found, we looked at insomnia. There was no seasonal influence on baseline symptoms at the beginning of treatment. So that didn't, which we were surprised. We thought it would be worse in the winter. It wasn't. But what we found is that people who were going through treatment as the day length was increasing did better than people who were going through treatment as the day length was shrinking. Right? So basically, if you start after the winter solstice, that's when the daylight starts to get longer and longer. Those folks did better than the people who started after summer solstice when the light started going down. Despite the fact that if you start right after the winter solstice, you have less daylight overall than starting after the summer solstice. But for us, or what we found is that it's the increase in light across the course of treatment that actually predicted better response, both in insomnia and in either depression or anxiety, but not the other. I can't remember. It was either depression or anxiety that also got better as day length was going up. So we found this interesting seasonal component to the treatment, but not to the baseline symptoms. All right, with that, let's call it a day.
Just wait a little bit.
Well, thank you. Thanks, Professor St. Roman, for his lectures. This was his last lecture with us, and I welcome all of you to catch him during the break, discuss whatever curiosities, questions you have. And thank you so much for the two very long, extensively long lectures. You're actually officially 4 lectures with us. Thank you so much for your time and all the knowledge that you've shared. Thank you so much.
Friends, I'm really happy to share with you amongst us today. We have a very senior chronobiologist who in fact comes from Halbergian School of Chronobiology, and he started chronobiology in King George Medical College then, now it is university. Sir, he is also not big brother in terms of England, but he is an elder brother of mine, Professor R.K. Singh. He served here for a very long time as head of the biochemistry department. He also was mentor of Professor Narsingh Verma, sir. So can I request you, sir, to come here just for a second on towards the dais? Yeah. And it's really pleasure. Can I call Professor Santa Rajaratnam to do the honors, please? He says that it is his own department, so how can he be honored? But if I don't honor, my elder brother, who else is going to honor, right? So just a token of appreciation, Professor Santa Rajaratnam from Narsingh. Thank you very much, sir, for coming. If you want to say anything, you are most welcome.
And sir has been the founder president of Indian Society of Chronomedicine.
Thank you, Dr. Vinod Kumar, Dr. Verma, sir. Actually, when we started chronobiology, you see, I am working on chronobiology since last more than 30-35 years. I published my first paper on chronobiology in 1975, and that became the basis for initiation of Indian Society of Chronobiology in our country. And later on, after I think 30 years, we started Indian Society of Chronomedicine. So now, once we started, I took a long time because I was thinking that how the experimental part, because in case of Indian Society of Chronobiology, majority of our colleagues were from basic sciences. So I thought that there must be some coordination or association between a medical and non-medical. But then only the chronomedicine can be advanced. Because from Varanasi itself, you see, the first cadaver surgery was done by Sushruta in 500 BC ago, and he described many ways on the basis of time only, how one can perform surgery, how it will be better wound healing, and then later on Sushruta also described. So this time-dependent medication was very important in our ancient times. It is known to our ancestors. But now the Professor Halberg gave a new name with the characteristics of 3 terms, measure, amplitude and atrophy. And that is how we define now chronobiology. So in these terms, so these were the 3 important terms how we use. So now I can't say anything more, but I must congratulate Professor Verma because he is doing excellent work. Being a teacher, I can say that our all blessings are within our best wishes for the continuous growth of our Indian Society of Chronomedicine. Thank you.